Well, those things are. Yeah. Yeah, you gotta go to .it and then go top. Yeah, it'll. Yeah, you gotta click .it and then just put in my phone. I was loose, but because my brain's not. What do you think? I'm gonna have to sell my. What is that? No. My daughter a little bit more space. There's who buy yeah. Better now. Te voy a bajar de tu nube. Yeah, it's gonna be the other way around. Le mandé was for 36, they wanted 35. 37,000, they wanted 35. Oh, 35,000 for it. You doing finally? Somebody had these playgrounds.
Okay, is everybody logged in that wants to be logged in to play the game?
It's okay.
She's on.
We'll have it.
Okay. Let's go ahead and get started then. So as you guys can see, we're back in rows. Okay. So I had to make some decisions yesterday because the numbers keep going up in our area for COVID and flu. Okay. Flu A is becoming very prevalent. Doesn't seem like it's been covered by the vaccine. It mutated enough that the vaccine's not really keeping people from getting it. So because of that, I'm trying to be proactive and keep you guys from hopefully getting sick. So if you do feel unwell, please wear a mask. Okay. If you're not running a fever, that you can come. If you know, because the numbers are going up, I know we have the whole policy about absences, but we have to be somewhat lenient. I don't want you in here exposing everybody. Okay. So if you think you have it, don't come because Amanda's like, oh, if you're like, oh my gosh, Amanda's gonna pluck me. Okay, no, we're not going to, because if it is COVID or flu related, we don't want you to spread it to the rest of the class. Okay. So, you know, again, I need you guys to also on the flip side, be honest with me. Okay. Don't use that as an excuse, because if you're out 4 times this semester for 2 weeks at a time because you've been exposed or you think you have the COVID, I'm going to be like, okay.
You need to wear masks.
Yeah, you need to be vaccinated and you need to wear a mask. Wash your hands. So just make sure that if you are ill, wear a mask. If you feel uncomfortable and you want to wear a mask while you're in here, you can. We are even considering possibly making allied health wear a mask again. Okay, just because we are higher risk because we are working in the healthcare environment. Okay. Hasn't been fully decided yet. That's why we're not in mask this morning, but we are separated a little bit more by the rows again. Okay. Cool. Okay. So today we're going to talk about postpartum care. So we talked about conception, development. We talked about the pregnancy process, the labor process. And so today we're going to talk about what do we do after we have a baby. Okay. You're still high risk. Okay. This is probably when most people are going to be high risk when they weren't high risk at any other point. Okay. Because you don't know how that person's going to bleed post-delivery. Okay. They may have no signs and symptoms or factors that make you think they're going to be one that's going to hemorrhage, and they'll be the one to hemorrhage. Okay. There are some key risk factors we'll talk about that are potential for hemorrhaging, but you know, some people may have a bleeding disorder and don't know it, you know, and they don't know it until they start to have those bleeding issues with a delivery, because that's the only time in their life that they would have ever had a time they would lost a lot of blood. Okay. So these are your student learning outcomes. Again, tomorrow, my plan is to do review. Okay. We're going to do probably either maybe both Kahoot and Jeopardy, but we're going to play game style reviews. Okay. But then we'll also, as you go through tonight and look through things, or as you remember, okay, I don't quite remember what we talked about there, we'll review fetal strips again. If we don't have an opportunity today in class, we will tomorrow in class. Okay. Like I said, the main thing is I want you to know the basics. Okay. Variability, your veal chop. What are those actual decels? What are they caused by? Okay. And then what are our interventions? Because you can look at a strip and go, oh my gosh, that baby's heart rate is dropping with the contraction, after the contraction, or just whenever. I need to do something. Okay. You at least will know those basic things. And then we'll do review. We'll do some fetal monitoring strip reviews because you're going to have a basic couple on there. So don't panic. Okay. But I'll kind of give you a really good idea of what you should know for testing purposes on Tuesday, because Monday you're out, because we have covered a ton of content this week. Okay. Not going to leave you drowning. Promise. Okay. Okay. So another word for postpartum is puerperium. Okay. The puerperium time in a woman's life. So that postpartum period. This is when your readjustment, both of physical and psychologically, back to a non-pregnant person. It's birth to 6 weeks. We have to look at family-centered care because now, yes, mom is still important. Yes, baby's still important, but now we have other factors. We've got siblings, we've got grandparents, we have dad that are part, or spouse or significant other, whoever he or she may be, is part of this whole family-centered care. Okay. So we got to look at that. What adjustments are being made for everybody due to this delivery and this newborn? So initially, that acute time is the first 6 to 12 hours following delivery. Okay, there's 3 phases that we're going to see during that postpartum period. That initial phase, and that's that first 4 hours we talked about yesterday. Then you're going to have a subacute phase, which is those first hours after the 4 hours. And then you're going to have the delayed phase, which is after the 12-hour period. Okay. Up to 6 weeks, because you can have issues up to 6 weeks postpartum. So that initial phase are going to, like I said, hold on, I told you wrong. My notes I had were incorrect. So the initial phase is the first 12 hours. The subacute phase is the first 2 to 6 weeks, and then the long is 6 months. Okay, we're going to go through each one. So the rapid changes are occurring. You have potential for hemorrhage, uterine inversion. Can someone tell me what that means? Your uterus inverts to where? Outside. Okay, the uterus can actually come out the vaginal canal outside. Okay, has anybody ever seen a cow give birth? Okay, sometimes they're at risk for having uterine inversions. Have you ever watched Dr. Pole? Love Dr. Pole. One of my favorite things to watch. Yeah, it's like a prolapse. Yeah, it goes out. Okay. Amniotic fluid embolisms. Does anybody know what that is? It's really bad. That's a good way to put it. So basically, because remember how we talked about sometimes baby's blood can accidentally cross into mom's blood? Well, sometimes that amniotic fluid can cross into mom's blood. Say she abrupts a little bit. There's open vessels there, capillaries that amniotic fluid can get in. What's inside amniotic fluid? Think about what comes off the baby.
Isn't it urine?
Possibly meconium if they poop. Lanugo, the little hairs that slough off. The vernix, okay, that possibly can be floating around in the water. And are those small particles? No, they're not. They're big when you think about it floating into mom's bloodstream and then through her body. So an amniotic fluid embolism is not just amniotic fluid that gets into mom's blood, but it's the particles that are within that fluid that causes that embolism. Okay, so just like a blood clot, the blood clots and gathers, and you've got this big ball of clots floating around. It's a ball of little lanugo or vernix floating around in mom's system. And what happens? It floats to where? Heart, lungs, brain. Okay. So with amniotic fluid embolism, we'll talk more about this. It's an emergency. Okay. It's very uncommon for a woman to survive it. They can, but it's uncommon. And it's one of those things that she's just delivered, everything's gone well, She's holding the baby, and all of a sudden she's like, I can't breathe.
What does it present like a heart attack?
It presents like a PE, like a pulmonary embolism. It's like, I can't breathe. I can't breathe. My chest hurts. I can't breathe. And then all of a sudden she's going to pass out, and you're going to be like, oh my gosh, what's going on? You know, you're checking her blood pressure. Someone's starting to ventilate, and she's had an amniotic fluid embolism.
What do they test to see what it was or where it ended up at?
Well, just like with the PE, you can do scans, okay? But think about with the PE, we can give heparin, right, to help break down that clot. But with the amniotic fluid embolism, if it's lanugo and vernix, we really can't do anything, okay? And so it's very dangerous.
What's the risk for that?
Huh? Potentially, that's something they could do, just like they would if they had a clot or something. But still, if she makes it to that point, unfortunately.
Before.
Most of the time, you have no earthly idea it's going to happen until it happens. I think that's not good for you. Nope, there's no interventions we can do. There's nothing that's going to give us an idea that it's going to happen. It's just one of those things that randomly happens just out of nowhere, and it just happens. There's no risk factors for mom or baby. I mean, nothing. You just all of a sudden have a patient who went from being a normal, healthy, happy postpartum mom who just delivered to wham bam, she's totally. Okay.
Say unincluded sex with going to mom, where exactly would it?
So it's usually going to be through that, you know, how the placenta pulls away. So when a woman is delivering the baby, sometimes that placenta can pull away before the baby's fully delivered. And because you may still have some amniotic fluid in that area, then it's going to get behind that placenta and into those little capillary areas. And it can happen through labors. I mean, we may have some abruptions that occur we don't ever know occur because we really don't have any severe signs and symptoms of it happening. And so, like I said, a lot of times with these, you have no idea that it's going to happen. In fact, most of the time we don't. Okay. So that subacute phase is the 2 to 6 weeks postpartum. The changes we're looking at is hemodynamic. So what's changing as far as the blood system goes? Blood volume, right? Because how much blood volume did we increase by? 40 to 50%. Almost half of her blood volume has been increased. So now it's got to go away. So what's going to happen is this mom is going to have her body switch the blood back to kind of a water, and she's going to try to diurese. Now, what's going to happen in most women is they're not going to be able to pee out that fluid fast enough. So where's it going to go? Yeah, to their feet, hands. So a lot of these poor women who've already suffered with swelling in pregnancy, their swelling is going to get worse post-delivery for about a week. And I always try to, when I see a mom who already has some swelling, I try to educate them. Just so you know, when your body starts to go through that postpartum process, that blood's got to go back to water, and you're probably going to have swelling worse than you do now. And for some people, if they already have a lot of swelling, it becomes very uncomfortable. It's hard to walk. Because think about all that taut tissue. It hurts. Okay. Genital urinary changes. So why do you think your bladder, your tubes, your all that as far as the genital urinary system, what would change?
Coming back to play.
Okay, going back to place.
Doesn't have a baby on
Doesn't have a baby on it anymore. Maybe less urine output, but we're probably going to pee more because of diuresing. But think about, you know, you just pushed a baby out near that urethra. There may be a little bit of damage, trauma. Okay. If she had an epidural or had a C-section, she had a catheter in place. Okay. So she's at a bigger risk now, even though she was at a bigger risk for UTI prior, she's even at a bigger risk now because we've introduced a foreign body. Okay. So we've got to make sure that we're aware to watch and have her watch for those signs and symptoms. We're going to expect there to be a little bit of burning sensation and pain and discomfort with urinating. We will want her to follow that, you know, continue to monitor her temperature, continue to monitor that past that second, third day.
And numbing spray is the best.
It is.
Hospital can give.
Best thing they can do for us. Changes in metabolism. Okay, so remember, whenever she was pregnant, that placenta was producing hormone to make her want sugar. Okay, and so it kind of slowed that metabolism down a little bit because we needed to gain that weight, add in those extra carbs. So her metabolism is going to speed up a little bit. Okay. emotional changes. Okay, so we'll talk a little bit more in the lecture about some things we want to watch for, but every mom goes through ups and downs after delivery. One minute you're really happy, you're so excited, and the next minute you're just bawling your eyes out. Okay, and that's just a change in hormones. You have highs and lows, and we kind of expect that to last about 2 weeks for every person. Okay, that baby blues time. But then we do have to watch past that for some people. Some people may not have any history of clinical depression and develop postpartum depression. But sometimes if you have those risk factors already in place of mental health illness prior, then you're at higher risk of developing it. Okay. So the delayed phase, so this is anything that can happen from that 6 weeks on. Okay. So we know that postpartum time really can last up to 6 months. Okay, your body is still healing up to that year mark after delivery. So that's why most doctors will encourage you to take birth control post-delivery. They want your body to heal, to repair before you get pregnant again. Because every time you get pregnant, it affects your body. And it's hard on your body. And so if we can allow it to heal, especially if you had a C-section, they want you to heal at least 12 months before you get pregnant to allow that scar to heal. But there's things you've got to watch for. Okay, you've got to watch for any kind of subtle change that might occur. Muscle tone is going to be different. Those connective tissues are going to be different. Like I said, you may have been a size 0 double when you got pregnant. Guess what? You're not going to ever be there again. Maybe it's you. But those hips will have spread. You've got extra adipose tissue. You have striaea. And there are some people who are healthy and their body goes back really quick. But there's some of us that will never be the same. Okay. And so that non-pregnant state is different. So a lot of times that even affects the emotional stage. Okay. You were this way before and now you're this way. What am I going to do? Okay. My husband's never going to love me this way. They will. I promise. Okay. So what are some physiological changes? Okay. So involution is normal. Okay. We talked about uterine prolapse or uterine involution. If it can be bad if it comes out all the way, and that's when it fully prolapses. But that uterine involution is going to happen because slowly getting smaller. Okay, smaller, going back to that normal size of the uterus. Okay.
How long does it take for it to?
Well, initially, so when you first deliver, we're going to talk about that. When you first deliver, the uterus is going to be very small. Okay, so as soon as that placenta comes out and that doctor's there rubbing, helping to get whatever clots and extra blood out, trying to get the bleeding to slow down, that uterus is going to be almost down into that pelvic floor. Okay, but then once he's done doing that, then it kind of fills back up with blood a little bit, and it usually gets to about the umbilicus. That's where you're going to expect most postpartum moms as soon as delivery is over, and that first 30 minutes is going to go back up to the umbilicus. So every time you go to massage, you want to make sure it stays at the umbilicus or below. Okay. So immediately you have a rapid reduction. Okay. The estrogen and progesterone are decreased due to the placenta separation. The uterine cells begin to atrophy. Okay. And like I said, immediately it's going to get really small, but then most immediately after that, it goes back to the umbilicus. Okay. Then the healing of the placenta site takes up to probably 6 weeks. And we tell most of our moms, nothing in the vaginal canal for up to 6 weeks. So no douching, no tampons, no intercourse. And the reason is because that is an open wound inside that uterine cavity. Okay, we don't want to introduce anything in there that could potentially cause an infection. And so some doctors will say 6 weeks or when the bleeding stops. Once the bleeding stops or the discharge stops, we know that it's healed over. Okay. So that tissue that's coming out, remember we talked about the other day, that endometrium kind of becomes that cushion inside the uterus while you're pregnant. So that's what you're losing. You're losing blood in that endometrium. That's why it's called lochia. And it kind of has a particular smell to it. And so I always encourage my patients to not be scared, to know that it's normal. You're going to have a little bit of an odor to it. What's bad is if it changes, like if it becomes kind of like a foul odor or like a rotting meat kind of smell. That's when we need to know, because that's the signs of possible infection. Or if the discharge you have starts to have some purulent drainage with it, like that green pussy look. Okay. Through that time, you know, your uterus is going to continually cramp early on. Okay, so as soon as you deliver, they're going to cramp. If they're breastfeeding, it's going to cramp more. Okay, and actually, breastfeeding moms will tend to bleed less than someone who bottle feeds, and because their body's naturally getting that oxytocin from the baby whenever it causes when it attaches, the body starts to produce oxytocin and prolactin to then produce milk. And so that's going to cause that uterus to cramp down. Okay. C-section moms also tend to have a little less bleeding, and it's because once they've made the placenta has come out, the physician will actually take a towel and go in and kind of clean out the inside of that cavity. And so they tend to bleed a little less too, because they've actually kind of had it removed by the physician whenever they've done the surgery. So you'll notice that your C-section patients won't always bleed as heavy either. So oxytocin is that natural hormone release from the posterior pituitary gland, and that's going to help reduce that size of the uterus, but also help with breastfeeding. It's going to help produce that milk. Sometimes with healing of that placental site, you can have some scarring. Okay, so you know, the more babies you have, the more scarring you have, and you do kind of increase your risk for possible miscarriage. And it's because when you scar, then it doesn't have as well of a place for that to burrow in every time. Okay. So after delivery, where should that fundal position be? Okay. We kind of already touched on this. So we expect it to be the top portion of the uterus, which is the fundus. Okay, you hear me talk about the fundus all the time. That's that very top portion of the uterus. So it should be midway between the symphysis pubis and the umbilicus. Okay, that's initially. And then it's going to kind of float back up to the umbilicus. So if it's at in between the pubic symphysis and the umbilicus, we're going to measure by finger breath. Okay, so a finger breath is a finger. Okay, so when you go in and you massage the fundus, you're going to see how many fingers can you put between the umbilicus and the top of that fundus. Okay, if you only feel about 1 finger width between there, that's 1 finger breath. If you feel 2, that's 2. And so when you go in to document it in your chart, you're going to see U plus 1, that's 1 above, or U minus 1, that's 1 below. Okay, so U is your umbilicus, and just kind of like with our stations, it's a little bit backwards, because on our stations, as baby progresses down, that's a positive movement and we're positive. But on the fundus itself, if you're at U and you're below it, then it's a minus. Okay, so it's flips. So we have U, and that's what we're judging by. Umbilicus. Where is that fundus compared to that umbilical site of mom? Okay, is it 1 below, 2 below, 3 below, or is it above? Okay,
Pretty easy to feel.
oh yeah, it feels like a hard ball. You're going to be able, it's easy to feel. Even on someone who's a little bit heavier, you may have to do a little bit more digging deeper into the abdomen, but you can find it pretty easy as long as it's hard. Now, if you go in and you can't feel it, then what's possible potential going on? You probably got bleeding, because what's happening to that uterus? It's not contracting. It's soft. It's mushy. It's boggy. Okay. You can't feel a nice hard ball in there. You better start rubbing. Even if you don't know where the top of it is, once you start rubbing that tummy, that uterus is going to contract, and then you're going to start to feel it firm up. You'll be like, oh, there it is. Okay. And you need to also assess the bleeding.
So is negative a good thing?
Yes, we want it to go negative. We want it to go down. Okay. So immediately it should be 1 to 2 finger breaths below the umbilicus. That's when we go in to feel it. Okay. 6 hours postpartum, it's still going to be about 1 to 2 beneath. And with every day, it's going to go down by 1. Yep, by 1 finger breath. Okay. So by day 10, ideally, you should not feel the uterus in the abdomen. It should be down below that pelvic bone.
But by day 10, I mean, they're home already, right?
Right.
We check that then, or
Nobody.
when they go back to the OB?
When they go at 6 weeks, they're going to check then. But at home, as long as their bleeding's not heavy, we usually don't have them assess it. So the fundus should go down by 1 centimeter every day. So that first postpartum day, it's gonna be U minus 1. Postpartum day 3, U minus 3. Okay, and my minus sign's in front of the U instead of on the number. By day 10, it should be in the pelvis. True or false? Bones. The finger breadth is the width of a finger used to measure the location of the uterus in a postpartum mom. Sure. True. So a finger breadth is 1 finger width. Okay. So now we're going to talk about the bleeding. Well, let's see who's at top.
Marisol.
Hi, Marisol.
Is it Marisol?
Hi, but that's not me.
Oh,
Sorry.
okay. So subinvolution. Okay. Oh wait. Yeah, we're on subinvolution. So this is when the uterus fails to go to that normal size. Okay. So typically this is a result of late postpartum hemorrhage, meaning 24 hours to 6 weeks. So signs and symptoms you're going to see is the spindle height is found to be greater than expected, so it's not progressing that 1 centimeter a day below. Okay, it's staying the same or maybe even getting bigger. The lochia fails to progress normally, so instead of going rubra to serosa to alba, it's staying at that rubra serosa longer than 2 weeks. Because by textbook, you should be to that alba by 2 weeks. Some people do have bleeding off and on up to 6 weeks, and we usually don't get concerned. But if you get past that 6 week time, or it's heavy before that 6 week time, then we get concerned. Okay. So causes of subinvolution is failure of regeneration of the placental site, which is the last area of the uterus to regenerate after birth. Infection, so they're going to have a foul-smelling lochia. Faulty implantation, so maybe it was like in the lower uterine segment of the uterus. And so it's not very vascular there, so it's harder for it to heal in that area. So if you have someone who has like maybe a low-lying placenta, partial previa, then you're going to possibly see it's not going to go down as fast. Retention of placental tissues. So this is why whenever we do a delivery, the baby's born and the nurse charts SVD as viable, male or female, by Dr. So-and-so, okay? And that's spontaneous vaginal delivery, that's what SVD stands for, or C-section delivery, whichever one it is, or if you use a vacuum, you're gonna chart that you did a vacuum, or forceps for use, you'll put forceps in. So when the placenta comes, we have to document placenta. So however the placenta comes out, which if it's spontaneous vaginal delivery, again, SVD of intact placenta. Okay, but you're going to have to look at that placenta, and that's your job as the nurse, not the physician. He's not going to really look at that placenta unless there's something abnormal that he sees. Okay, so you're going to take this placenta, and we talked about the shiny Schultz, which is the inside. That's where that inside of the placenta is to baby, and you've got the amnion and chorion attached to it. And then the dirty duskin is the other side. That's the part that's attached to that uterine wall. So you really can't take that sac and make sure it's whole because it's kind of pieced apart. But you can look at the back side and the front side of that placenta, and you can see if something's missing. Okay, see, because it kind of looks like lobes. Okay, if you're missing a piece, you're like, well, where'd that piece go? Well, if you have a patient who's bleeding, and you can't get them to stop, then you have to wonder, do I have retained placental parts still inside the uterus that maybe that piece didn't fully come off the uterus? Okay. So that's one risk of possibly someone who their uterus isn't coming down and they're still having heavy bleeding. So what would we do in that case if we have placenta that's retained? Would we just do them as sponges? Possibly, that might help cause it to contract enough.
They put their hand in like.
Yes, so if it's retained placenta parts and the physician's still there, yes, they can take their hand, put it up through the vagina, through the cervix.
Only?
The physician only, and we'll kind of slough the inside of that uterine cavity while they're pushing bimanually from the top. If that doesn't work, then they're probably going to have to go back to the OR and do what's called a DNC, which is a dilation and curettage, which means they're probably not going to have to dilate the cervix too much because it's already open, but they take a curettage. It's a long instrument that kind of has a triangular top, and they actually go in and scrape the inside of that uterine cavity to remove whatever they can. Okay. What's the risk with this? Bleeding. Okay, if that uterus cannot contract down, then it's going to bleed. Okay, this is another reason we could possibly have postpartum hemorrhage. It's retained placental parts. Okay. You can also have subinvolution, like I said, that lasts or is after that 4 to 6 week period. And so this is one where it's probably going to be sort of most related to like infection or a lower uterine segment implantation. And so they're going to give methergin. Okay. So you're going to learn about methergin and farm, but we also not only use it post-delivery immediately for bleeding, we can use it at that later postpartum period to help with bleeding. Okay. So you're going to give it PO every 3 to 4 hours for about 1 to 2 days. Okay. To help stop that bleeding in mom. And we're talking, this has to be like she's bleeding like really heavy period days for several days in a row. So blood loss. Where'd my Lokia go? Okay. Talk about blood loss, and then we'll see what's next. And then if it's not Lokia, then we'll just have to go over Lokia, and I'll give you the. You should have. Do you have the Lokia? Okay. Don't have the slide, so we're gonna go over it without the slide. Okay.
Would the Pitocin also be a choice or no?
Immediately after delivery, yes.
Just immediately after delivery?
You don't do it later. No. Pitocin is just given immediately after delivery to help with bleeding, but not later, like 4 to 6 weeks after.
And it wouldn't help contract the.
Because it's not necessarily the contraction of the uterus by then, it's just you're having heavy bleeding, so you need the bleeding to stop. And so that's going to actually, methogen works a little bit different than just causing the uterus to contract to cause bleeding to stop. Okay. So Lokia, without the slide. Okay. So the first 2 to 3 days is rubra. Okay. So I always tell my patients the first day to 2 days, it's going to be like the heaviest day of their period. Okay. They're going to bleed pretty heavy. They may even have some clots. As long as the clots are nickel size, they're okay. Fun size or more, so about the size of your fist or bigger, is not okay. Okay. Now, every great once in a while, you'll have someone who'll call you and we'll have passed the bigger size clot. And I usually then have to do a little bit of investigating. Okay. So I'll find out, had you just gotten up out of bed and been asleep for several hours? And if they say, oh yeah, I've been asleep for about 4 hours when I got it. Well, think about it. You're laying down flat. That blood collects inside the vagina. It's going to coagulate. So it's not necessarily up in the uterus, it's in the vaginal canal. And when they go to stand up and go to the bathroom, it's going to come out. Okay. And then, so then I assess their bleeding then. So I look at the pad. How are they bleeding at that moment? If you don't have an active kind of like where you can see it's real bright red or heavy or bleeding, it's probably related to them having lying flat for such a long time in the day. Okay. But if you see the clot and they're still having some pretty active heavy bleeding at that moment, then we need to be concerned. We need to fill that uterus and go on. So right after delivery, we're going to massage the fundus every 15 minutes for 2 hours. We talked about this yesterday. Okay. And then after that, we're going to still assess it 1 to 2 times a shift. For sure, when we do our shift assessment, but sometimes if I have someone who has a bigger, fuller uterus, I'm probably going to assess it again. And then still, when you go in to check on your patient, you're going to say, how's your bleeding? If they're like, oh, it's normal. Or if they say, oh, it's a little heavier, then that way you can go back in. We keep those red boxes bathroom and you can assess those pads. Okay. So 2 to 3 days, they're going to have severe bleeding, possible clot. How are we going to describe it when we chart it? We're going to go by scant, moderate, or heavy. Okay. So scant is going to be, so when you see that, you've got your 4 pads there. Scant's going to be like the size of a quarter, maybe a little $50. Moderate is going to be about half the size of a dollar bill. Heavy is going to be, you've kind of almost filled that whole pad. And then hemorrhaging is going to be the whole pad's full. Yeah, completely soaked. Okay. So how fast should a woman fill a pad? You know? As long as they're not filling pad every hour, then that can be normal. Okay. If you fill a pad in less than an hour, then that's considered too heavy and we need to reassess what's going on. So I always educate my patients right after delivery. Let me know if you're filling a pad faster than an hour. Okay. Now I always tell them it's not that you go to the bathroom and pee and you change your pad every hour because it's got sun blood on it. We're talking the pad is saturated. Okay, let's see.
What was the last? The last one, it was heavy.
So hemorrhage, like if you're hemorrhaging, that pad is going to be fully soaked and saturated. So how can we tell how much blood loss they've had? We're going to weigh the pad. Okay. So we're going to take a normal dry pad and we'll weigh it to see how much it weighs. Okay. Then we're going to weigh our bloody pad and then we'll subtract the dry weight. And then for every gram, that's 1 ml of blood loss.
But that's just your soap pad.
Yes, if they're bleeding heavy, that's what we're going to do. Or say right after delivery and they're bleeding heavy, and you've got your blue chuck pads underneath them. That's someone who's bleeding pretty heavily. You may want to save those, and we need to weigh them so we can have an accurate blood loss. Because your physician's going to kind of guesstimate. Okay, he's going to look at how much blood is in that funnel bag, how much blood is on the bed, and he's going to do a guesstimation. Okay.
Each gram is what?
1 gram is 1 ml.
1 to 1.
So you're bleeding cirrhosis, so that's not that super heavy anymore. It's more of like a typical period, maybe lighter blood. It's going to be 3 to 10 days typically. And then alba is kind of like that light pink to white. It's going to be 2 to 3 weeks. So once the lochia has stopped, the cervix is closed and your uterine vault is usually healed.
And cirrhosis just looks bloody.
Yes. So it's kind of like a pinkish light blood to white color also, but the lochia is going to be more real light pink to white. And so that is a combination of blood, still a little bit of maybe tissue and white blood cells because your body's healing that site. And that's why your lochia alba is white. Quiz, as I did blood loss, sorry. When weighing a blood fill pad, 1 gram equals 1 what? ml, which is also 1 cc, right? Okay, we don't use cc as often anymore, okay, because it can be very confused with something else. It may look like a 0. So 1 ml and 1 cc are exactly the same. Okay, it's the same measurement. We just tend to use ml more now. Okay, so blood loss, if I get that one, look at your page. So with a vaginal birth, your blood loss is going to be about 200 to 500 ml. A C-section is going to be about 700 to 1,000. You're going to see your hematocrit is going to drop about 2 to 3 points, which indicates 500 ml. Your hemoglobin 1 point drop indicates approximately 500 mLs. So if I have a hemoglobin of 11.4, okay, the day she delivers, and my next day postpartum, it's 8.4. How many mLs of blood loss have I had?
2000.
1,500. Yeah, 1,500, because we're 3 difference by 3, right? Every one is 500, so 500, 1,000, 15. Okay. So if you had a test question with your initial blood loss hemoglobin or your initial hemoglobin, and then your post-delivery hemoglobin, do you think you could calculate approximate blood loss for me? Okay. So for every point dropped, it's 500 mLs. Okay, and that's kind of a good way, other than weighing your pads, that's going to be a good indicator of your blood loss. And so that diurese, where their blood flips from blood to water, is about the first 2 days postpartum. So that's why I always tell my moms that they're going to see their legs get bigger that first week. Okay. Let's see if you got, who's ahead still? Ooh, Marisol. Marisol's still ahead. Okay. Oh my gosh. Me and the clicker. I'm putting the clicker down. Okay. Because I wanted you to see the picture. Okay, you have your picture there. Look at your cervix. So a first time mom, the cervix is going to look like a fist with just a little dimple. Okay, so you got your golf ball there. Everybody knows what a golf ball looks like. It has little dimples in it. And that's kind of what the opening of the cervix looks like, just a little dimple. Yes, it's a second, third time, fourth time mom. They tend to have more of a fish mouth look to the opening. That's why. It's already stretched. It's been stretched, it's been torn, and now it's come back together and gotten smaller. So you're not really ever going to have that same little dimple. Some people may not have the fish mouth look. It may still be circular, but it's not going to be a little dimple anymore. And remember, your second, third, fourth times mom sometimes can walk around 3, 4, 5 centimeters, not contracting and not really in labor. And it's just because that cervix is already dilated and changed 1 time before. So as gravity takes over and baby comes deeper into that pelvic inlet, then that cervix is going to start making some changes, but you're not really in labor. It's just like, oh my gosh, baby's on me. So it's going to start to open a little bit. Okay. So following delivery, that cervix is going to be very spongy, flabby, formless. You can have lacerations to it. So if you have a mom that you go in and you're assessing her uterus, you're massaging the fundus, it's nice and firm, but every time you go to push to assess for blood clots, you have to massage and kind of push a little bit, you have a gush of blood coming. But your uterus is nice and firm. So potentially, if that's going on, you had a laceration in that cervix that the doctor wasn't able to see because the cervix is still up into that vaginal canal. So if that's going on, you need to let your physician know, because they're going to have to come to a speculum in and look at possibly up the cervix itself. Okay. So this is why we encourage our moms not to push before they're complete and 100% safe. Because if you start to push prior to that, you're going to cause swelling. That tissue is going to become edematous, and then it becomes very fibrous and very easy to tear. Okay. So we want to make sure that our patients aren't pushing until it's time to push. So perineum. Okay, so we've got our cervix inside that's going to open and to 10 centimeters and be pushed out. Your vaginal canal, which can still have possible lacerations, but your perineum is going to be the part that you're going to see tear the most, okay, or have lacerations the most. Okay. So we're going to remember when we're assessing the perineum, if they've had any incisions or had any sutures, or even if they haven't had sutures, you need to assess the perineum at least once or twice post-delivery to make sure that you don't have too much swelling going on. So Rita is your friend when you're doing assessment of the perineum. Okay. So you're looking for redness, edema, ecchymosis. What's ecchymosis? Bleeding under the skin, so like bruising, drainage, and approximation. What does that mean? Right, if the stitches are remaining closed, okay? So if you have someone who's stitched up and they're having lots of edema, you're at risk of pulling those stitches and causing the approximation to not be good, okay? So that's when we're gonna offer the Dermaplast spray. We're gonna offer ice packs. We even will give them tux pads to use for hemorrhoids, but they can even use that on that perineum. We'll even kind of like just fold them over and put it right up against there and then pull the pad up to it, okay?
This is all just during natural birth.
Yes, this is after you've had a vaginal delivery. Yeah, unless, say you went through labor, you pushed for 3 hours and then had a C-section, you still need to assess that patient's perineum because you may not have lacerations, but you're gonna have swelling. Yeah, you're gonna have swelling and you wanna make sure that that's slowing down, okay? So Rita is something very important to know. Okay. If they have that going on, then we're going to do the Dermaplast Ice Motrin. Why Motrin? It helps with swelling. It's an anti-inflammatory. Okay, so we want to, if it's darker floors, it's going to be naproxen. If it's darker K, it's going to be Motrin. So if you're giving them a Percocet because they're hurting really bad, go ahead and offer them that Motrin and explain to them that it helps with inflammation, and that's going to help with the pain a little bit differently than like a Percocet will. Okay.
But if they're bleeding, you put it.
No, you can give them a Motrin. Yep. You can give them a Motrin because you got to think they're going to have to take that Motrin for several days, like 7-10 days in a row to then really affect the thickness of the blood to cause more bleeding. Okay. You could do sitz bath. Does anybody know what a sitz bath is?
Isn't it just like a little thing that you throw in the toilet and you sit
Yeah.
on?
So a sitz bath is circular. We don't really keep the sitz baths anymore, but I'll explain what you can have them do instead. So it's a little circular bowl that you sit in the toilet. It has a little bit of a depth to it, and it also has a tube. So you actually just sit on there and spray your perineum with like warm water, okay? And that just helps to kind of feel better, okay? If you don't have access to a sitz bath, you can tell them to fill the bathtub with just a few inches of water to where they can sit in that with their bottom. Of course, we want them to clean the bathtub first, and that will just help also soothe that area of the body. Okay, so you can do heat and cold. You don't want it too hot, you just want to do warm. Okay, peri bottles. This kind of helps too. Kind of has the same idea as the sitz bath. You can have them fill it with warm water when they go to use the bathroom, especially if they have what we call skid marks or kind of like striaea, so that tissue has stretched. So it's not a true laceration, but think about when you kind of stretch your skin too much, it kind of breaks open just a little bit in a few little places, or you have a carpet burn. You know, a carpet burn is not really a laceration, but you kind of peeled that first layer of skin off. Kind of the same idea. So it's going to burn when they go to urinate. So you want to fill that peri bottle with some warm water and have them flush that area while they're urinating, and that will help reduce that irritation while they're urinating. Okay.
I was wondering what that bottle was for.
Yep, that's what that peri bottle's for. It's to help reduce the burning when you urinate, if you have a laceration. Okay, and even if you don't have like a true laceration, like I said, everything's been stretched, so it kind of burns anyways. Okay. Pain. So post-delivery, you're going to have pain, okay? Your body's going to cramp. Potential headaches, because think about when you push, all that extra pressure you're putting in your head. So a lot of people will complain about a headache. But if someone postpartum says they have a headache, do we need to probably check their blood pressure? Yeah. So we will go over preeclampsia, and you're going to learn about it in Pharm too, about the medications. But with preeclampsia, you're going to see someone who potentially could become preeclamptic even after delivery. Of course, we tell you that the way to cure it is to deliver, but you can develop postpartum preeclampsia. I've had patients do it before, okay, where we still have to start magnesium and do all that after the baby's born. Okay, it's not very common, but it can happen. And so we still need to continue to assess those things. If they start telling me that they have a headache and they kind of, everything's blurry, I'm gonna start checking their blood pressure, which I'm gonna be checking it every 4 hours, so I'm gonna have to assess it a little bit more often, okay? Because there is a potential of postpartum preeclampsia. And those after pain, okay, or cramping, and you'll notice that if you've had 2 or 3 babies, by that 3rd and 4th baby, you think you're gonna die, okay? Literally. Like I took ibuprofen with all my other kids until I had my last baby. And like I was calling the nurse, I'm like, I need something more. Okay. The cramping gets worse every time. So when you have a mom who's had 3rd, 4th baby and she's really complaining about those cramps, it's true. It hurts. And this is statistically proven. It tends to get harder with every delivery the cramping does. Okay. And think about it, it's because that uterus has been stretched however many times and your body's having to work a little extra hard to get it to really firm up.
Doesn't matter how many years have been in between.
Nope, that really doesn't even affect it. It just seems like for whatever reason, and after that 2nd baby, those 3rd, 4th babies cause more cramping. So if they're having to receive extra Pitocin, or they did get like Methadone or something, they're gonna have a little bit more discomfort because we're making them cramp even harder. Okay, we're making them have a little bit more pain because we're trying to stop that bleeding. Again, breastfeeding is going to cause them to cramp up. So if they're complaining of cramping, again, if it's just cramping, mild cramping, I start with my lowest pain medicine. You know, ibuprofen, Tylenol with codeine. If that doesn't go and work after an hour, then we can move up to something a little stronger. 800. We give 800. Episiotomy or a laceration, if they did tear, okay, they're going to have discomfort in that area. And again, ibuprofen is the best for that, just because it's going to help with inflammation. And then again, local help with like ice packs, dermoplast sprays. Hemorrhoids. Did y'all notice when we watched that video yesterday? That poor girl's going to have some hemorrhoids for a few days. And it's because you're pushing the same tissue that you have about movement you're using to have that baby. And so you're pushing on those rectal tissues and they're coming out. They're going to be swollen and inflamed because of all the trauma. But most of the time for most women, after a couple of days, the hemorrhoids go away. Okay. So that's why we offer the Tux pads post-delivery to just help with that discomfort. Muscle aches. Okay. If you have a mom that's pushed for 2 or 3 hours and you're having to pull those legs back or you're playing tug of war with them with a sheet, yes. You're going to have muscle aches. So is the nurse. Okay. And they're just going to be sore and their body's going to be tired because they did a lot of work. Homan signs. Does anybody know what Homan signs is? Okay. No. So Homan signs is where you have a person while you're doing their physical exam, you take their foot and you push it towards the top of their head. Okay. You're going to flex that calf. When you do that, if they're like, ow, 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 that hurts, that's a potential sign there's a DVT, okay? So Homan signs, we're kind of getting away from. Not as many people utilize it because it is not 100%. It's like 50, 60% proven to work, but we still assess it, okay? So when you go in to do your assessment, you're gonna push that foot towards the mom's head while she's laying in bed. As she starts going ow, 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 then we need to further assess for a possible blood clot. Okay. Chest pain. Why chest pain? Possible PE or the amnioembolism. That's one sign, but also just overload. Right. Okay. It's gone into some overload. It had to work extra hard during delivery. We've given her extra fluids while she's delivering. Now her body is switching that extra blood to fluid. Okay, so we're having a little bit of fluid volume overload on her. Okay, so she could have some potential chest pain. Backache. Delivery. Epidural can be local pain right where the insertion was, so you might complain about that. But if it's all over back pain, it's more so related to delivery, more so related to that body transitioning from that lordosis to now trying to go back and keep everything in, okay? So those back muscles are trying to help support, okay? So what do a lot of our Hispanic moms do? Stop. Does everybody know what that is?
Girdle.
It's a girdle, okay? It's an abdominal binder, okay? It works, okay? A lot of people are like, oh, I don't want to wear that. It's uncomfortable. But if you have that added support for those abdominal and back muscles, your pain will be less, okay? Because you're not having as much strain on those back muscles. It really works. Okay, so if your patient asks for a faja, she wants a girdle. She wants an abdominal binder. And sometimes they'll bring them with them, okay? But they truly do work. They really help. Post C-section, I encourage all of my C-section moms to wear one, okay? Because they needed that added support to those muscles because they've got to utilize their legs a lot to get up and down because they've had an incision through those muscles, okay? But that extra support really does help even on your vaginal deliveries because now your body's trying to pull in everything, hold it in, and it just gives that body a little more support and reduces some discomfort on your back, okay? So ovulation and menstruation. So non-breastfeeding moms are going to start ovulating and having a menses around 7 to 12 weeks postpartum, okay? Sometimes it can even happen 4 weeks postpartum. So my sister-in-law, my husband's sister that's right under him, he's one of 5, he's the only boy. He has 4 younger sisters. Calls me about 6 weeks after she had her son, crying. And I'm like, oh my gosh, Lisa, what's wrong? Because I'm thinking something's with the baby, right? Because I told you, everybody's going to call you, right? Because you're the nurse. I'm like, what's wrong? What's wrong? And she's like, I had a positive pregnancy test. Well, I'm thinking, okay, you know, is it a false positive? Is there some kind of cancer going on? You know, she just had a baby. It's not common without a molar pregnancy, but you can develop that choriocarcinoma post-delivery. So like my brain goes bad. And I was like, okay, well, did you go to the doctor? No, not yet. So she goes to the doctor, guess what? She's pregnant. Okay. Well, she didn't wait her 6 to 8 weeks like she was supposed to. And so she ovulated at some point in that first 3 to 4 weeks and got pregnant immediately. So my niece and nephew are, Zachary turns, so he just turned 16 last year. So he'll turn 17 in June. But his sister will turn 17 in May. So they'll be the same age for almost a month. Okay. And then his other sister, Amy, which is the one right under Lisa, is the same thing. She has 2 little girls that are 7 and 8 now. But in the month of December, they're the same age for about 3 weeks. So it can happen. So I always tell people, just because you know, they say until you have a period, well, you have to ovulate before you have a period. Okay, so you can get pregnant. It happens. So that's why we encourage moms to wait until they get to the doctor at least, or if they're going to have intercourse, use some other form of birth control. Okay, most effective is going to be a condom. You know, spermicide somewhat work, but your most effective is a condom until you can get either an oral birth control, IUD, implant. Breastfeeding. Some people will have no period the whole time they're breastfeeding. Some people will start having a period 2 to 3 months after they deliver, and it'll just be kind of light and irregular. So it's not 100%. If you breastfeed, that is not a way from keeping from getting pregnant. Because again, when your body decides to ovulate, you're not going to know that you ovulated, and you'll be pregnant before you know that you had a period or ovulated, right? And then you'll be like, 18, 20 weeks pregnant, starting to feel that baby moving, going, that's not gas. Okay, it happens. So it is not a reliable way to not get pregnant. Okay.
You tie your tube when you deliver.
if you tie your tubes once you deliver, you still have to wait because those have to heal. Because when they say tie your tubes, what they're doing when they go in there is they are taking the fallopian tube. So there's a couple ways they do it. So you have your fallopian tube. Okay. The doctor will then go in with scissors and cut about a 1 centimeter portion out. Okay. They'll take a suture without the needle on it. They'll tie it around there, tie some knots, special knots that are supposed to hold, and kind of clamp up that opening. So that has to heal over, okay, before you can truly be considered not able to have a baby. Now,
Can't those come back together?
they can't. The other one's like a Fauci clamp, and it's just like a metal clamp that clamps the cord, the fallopian tube down and causes it to scar. We used to have the, what was it called? We did them in the office. I don't do them anymore. It was a little coil that would go in there and cause it to scar down. But a lot of women were having complications with that migrating afterwards.
How long do the tubes take to heal?
So usually they're going to tell you 6 to 8 weeks to allow them to heal. But I had a patient in Dallas, had her tubes tied, got pregnant, had a baby, had her tubes tied again, got pregnant, had a baby, sent her husband for a vasectomy. Like those 2 babies were going to come no matter what happened. You could have intervened and it didn't matter. Okay.
Vasectomies fail too.
Vasectomies can fail.
Down the line.
Just because they pretty much do the exact same thing that they do to the fallopian tube. They do to the tube that goes from the testes to the penis. Okay. They go in, they separate the skin or make a little incision. They're pretty close to the top of the tissue. And so they'll take it, pull up, take that portion out. But most of the time they recommend the men go back about 6 weeks later and do a sperm count to make sure that there's no sperm. So yeah, there's lots of TikTok videos out there of men who've had vasectomies and they think they got their spouse pregnant. So they go dip the stick in the wife's urine in the toilet in the morning and they know they're pregnant before the wife does. Yeah. You haven't seen any of them? There's several of them out there. Anyways, so yes.
Send them on remind.
Right. So, you know, they can fail. They're not 100%, but they are closer to 100% than other things are. Okay. There is a possibility of failure.
So are you saying like they went to the doctor and found out their vasectomy failed? Like how would a man know?
Well, I mean, think about it. If you're with someone, they're going to know your symptoms, especially if you've had several kids with them. You know, you're grouchy, you're tired, your boobs are sore. You know, they start to notice those symptoms. Like my husband knew I was pregnant with my son before I knew I was pregnant with my son. And it wasn't because he did a test. He was just like, you're pregnant. Okay, I'm not pregnant. He's like, yes, you are. And my daughter was 8 months old. And I was having irregular periods and we weren't being real cautious about what we were doing. And I was like, there's no way. He's like, there's a way. And I was like, okay. So I went to the store. I was about to go to work. I took the test and I cried the whole time in the bathroom. I was very scared because I was like, my baby, don't be a baby because I'm having another baby. It was wonderful because they grew up to be best friends. Now they're 15 and 14 now, and they still like each other somewhat. Now don't mess with one or the other because the other one's going to get you. But they can mess with each other and it doesn't matter, you know. So, you know, it's one of those things that when you find out you're pregnant and you have a baby, it can be a little scary. Okay. So how does the body change? So now we're going to talk about how our body goes back. So the abdomen has uterine ligaments that are stretched, and this takes a significant amount of time during that postpartum period to recover. They have to go back to normal size. And then think about a rubber band. You can stretch it and stretch it and stretch it, but at some point the stretchiness is not going to be as good as it was when we first started stretching it, right? So those tendons tend to kind of get a little relaxed over time. So although the belly can seem flabby, the abdominal wall typically responds to exercise within 2 to 3 months. Okay, so it's not just the exterior skin. That skin may never go back the same, but you can work those muscles to go back to normal. Now, if you have the separation, that can take a little longer. And like I said, sometimes that will never go back together for some people. That diastasis rectus. It can be more pronounced in women with C-sections because they have actually gone in and separated those muscles to get to the baby. Okay. Most people's body will naturally heal them back together, but sometimes it don't. It doesn't. It'll just have to be left that way. You can strengthen those muscles to where the separation's less, but some people will actually go in later and have surgery to repair them if they need to. Stretch marks, they should fade over time. Okay, they go from red to kind of a silver color, dark to kind of lighter, but they usually never go away. They're always there. Okay. As you start to lose weight, they tend to get smaller and they're not as noticeable. The breast, you start to produce a colostrum the first 2 to 3 days. That's the initial milk. Sometimes you can even have leakage of this in pregnancy because your body's already started to produce it. Sometimes, remember, as early as 12 weeks pregnancy for some women. Colostrum is only a small amount. Okay, this encourages the baby to feed more frequently, stimulating the milk production in mom. Remember, we called it liquid gold, kind of thick and creamy and yellow in color. It has antibodies, protein, fat-soluble vitamins, minerals, and it can also kind of have a low amount of lactose if you eat dairy. It can also have a laxative effect, which encourages the passing of that meconium stool and helps to reduce the baby from having that hyperbilirubinemia, okay, or jaundice. Kind of amazing how our bodies naturally do the things we do. It also promotes for normal flora in the digestive tract to help prevent disease and illness. So does anybody know in recent studies how we've determined a baby gets their normal flora? Skin to skin, but also another way. Through the vagina. That baby who's born vaginally passes through that vaginal canal, and that's how they develop their normal flora. That's why more facilities are encouraging moms to delay baby. Sometimes it can be 8 hours, 12 hours, 24 hours. It depends on the facility. Here we don't really have a policy on how long to wait. It's just till baby's temperature is stable. But a lot of times we'll try to educate and encourage. You know, we want that vernix to absorb. That's one thing. But then we also want to leave that flora from mom, that natural bacteria on baby, because that's what's going to help develop baby's flora. Okay. And they've actually done studies where they've gone in and collected specimens of stool from children, from their parents, grandparents, and you can see they tend to have the same type of natural flora. Okay. So what do you do with a C-section baby? Skin to skin. There's actually some facilities that will collect the vaginal swab of mom prior to C-section and will swab the baby down after delivery.
They don't tell you that, do they?
No, they do.
They do?
Yep, they're going to tell you if they do that. We don't do it here unless they ask us to. And we've had a couple people if they've educated themselves on normal flora. Okay. So that's how you get your gut flora. That's how you get your natural flora on your skin. It comes from your birth. Okay. Of course, as you're exposed to different things environmentally too, but your initial exposure to mom is what gives you that natural normal flora.
Does that help with you, like your immunity and fighting and all that?
Yep. So that's how like your gut flora helps to fight off, because when you eat something that has something in it, of course, the first initial is your mouth. You have a little bit of acids produced. Then when it gets to the stomach, you have the hydrochloric acid that's produced by your stomach, and that helps break down any bacteria. But then also when you get into your lower intestines, they have natural bacteria that fights against the bad bacteria. So that's why anytime someone is on an antibiotic, they'll tell you to do like acidophilus or probiotic to help build your natural flora back up, because that antibiotic is going to kill that natural flora and you're at bigger risk of getting some GI issues. So with breastfeeding also, you're going to have engorgement. Okay, so the mom is gonna say, I don't have any milk, I don't have any milk, and you'll be like, yes, you do, yes, you do. You know, baby wants to nurse, put them to the breast, feed, 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 okay? Because that's gonna stimulate that milk production, and that milk is gonna come in about at 32 to 96 hours, depending on the patient's production, okay? So by day 2.5 to day 3 to 4, okay? So engorgement is that initial letdown of that natural milk, okay? Your breasts sometimes will grow 3 to 4 times their normal size. They'll be hard, they're gonna hurt. And so what we tell our moms is, you wanna just breastfeed, okay? Sometimes you don't, you know, like, oh, if you'll just pump. Well, no, you're gonna pump and your body's gonna think that they need to continue to make that amount of milk. So you're gonna continue with that engorgement. What your body is trying to do is regulate the amount of milk that you need for that baby. Okay, so initially it's going to give you a lot. And then as that baby nurses, your body starts to adjust to that baby's routine. Okay. You're going to have some pain, skin hardness. It's going to be really taut. It's going to be shiny. The skin will be. You can even sometimes run a fever. Doesn't necessarily mean you have mastitis. You've just got lots of inflammation in that tissue of the breast. So we want to do frequent feedings. We also want to look as, you know, is the baby not latching properly? Is that why we're not getting some relief with mom? Because you should feel relief with every time she nurses, okay? We can also do warm compresses to help reduce, because that will help that milk kind of reabsorb. A warm shower. If she's not going to breastfeed, then you're going to look at doing compression. Okay, so you're going to have wear a really, really tight sports bra, or you can even wrap an ACE bandage around them, and you want her to wear that ACE bandage as long as she can for the next 24 to 48, 72 hours. Only take it off when she showers. Okay. Another thing that does help is cabbage leaves. Have you heard that? Mm-hmm. Yep. Cold cabbage leaves. You put cabbage in their fridge, you take the cabbage leaves out, you put them on the breast, you wrap them up or put them in your bra, and that helps to reduce some of that inflammation also. There's something naturally in cabbage that helps to reduce that, and it really works.
And Hispanics, I know that they do like cabbage showers. Like,
Yeah. Yeah.
They boil up the cabbage.
Mm-hmm.
Or get it.
Yeah, help.
Reduce inflammation all
Yeah.
over your body.
So it does, and it has something that naturally reduces, that helps reduce that inflammation. Sore nipples, okay, we want to make sure if we have sore nipples, you're going to have a little bit of discomfort with baby breastfeeding initially, as those nipples toughen. But if it continues, or you notice that there's a breakage or there's bleeding, then we've got to look at latch. How is baby latching? If the mom, again, is not going to breastfeed, then we're going to do the wrap, cold packs, Tylenol, ibuprofen to help reduce with discomfort. If she is breastfeeding, we're also going to have to educate on mastitis. Okay, so if they notice like one red spot that's kind of a lump and soreness, you know, if they're breastfeeding at that time, they need to massage that area, and that will help release that milk that's clogged in that area. If it doesn't get any better over time, they need to see the doctor. They may need an antibiotic. So if they have mastitis, do they have to stop breastfeeding? No, you want them to continue to breastfeed. They just need to be given a safe antibiotic that can be taken while she's breastfeeding. Okay. Quiz. Breastfeeding is a reliable form of birth control. True or false? False. Okay, it is not reliable. Breastfeeding, you cannot count on it being reliable, because if you ovulate, you're not going to know it, and you're going to get pregnant, and then you're not going to know it. Okay. Woo-wee, look at there. We're moving and changing. So what are the cardiovascular changes we're going to see? We're going to have hypervolemia due to no placenta, okay, that blood loss. It protects with blood volume. You could potentially have hypervolemia due to the placenta coming out and having too much blood loss. Okay, my notes say that correctly. So it occurs immediately following birth due to maternal circulation and no longer traveling through the placenta. It protects from excessive blood loss. So the cardiac output decreases by 30% over 2 weeks and reaches normal by 6 to 12 weeks. Okay. Your heart rate, you're going to possibly have some bradycardia, 50 to 70 beats per minute occurring during that first 6 to 10 weeks, because you have that extra blood that your body's trying to get rid of, and so it's going to slow down your heart rate a little bit. Blood pressure, it may elevate immediately following delivery, then decline back to that normal pre-pregnancy baseline. You possibly could see orthostatic hypotension in the first 48 hours, okay? And what is orthostatic hypotension? What happens? Yeah, you have set up too fast, stand up too fast, and you get dizzy, and this can be related to that blood loss, okay? You can have a headache when you have that high blood pressure, but if you do have someone complaining of a headache and a high blood pressure, we need to do a little bit further investigation, possible testing to make sure they don't have hypertension. Postpartum diaphoresis. Okay, you're going to have a mom who's going to say, oh my gosh, I'm hot and sweating. Okay, this is another way your body is getting rid of that excess fluid. Also related to hormone changes. A lot of women postpartum will have night sweats. Okay, and this is just your body's natural way of going back to normal after delivery and getting rid of some of that fluid. And it's also related to hormone changes. Postpartum chills. Okay, you'll have a lot of women, especially when they get close to delivery, they'll start having the shivers and the chills. It's not necessarily related to them being cold, okay? It's a sudden release of pressure from those pelvic nerves after delivery. If it's before, it's kind of related to this shift in those hormones as your body is increasing the amount of oxytocin to help push that baby out. But post-delivery, it's related to that release off those pelvic nerves because you no longer have that huge baby sitting on them, okay? It's a responsive fetal maternal transfusion during placenta separation. Okay, so it's another reason you're going to have those shivers, that placenta is separated and your body's responding. Also, reaction to the rush of adrenaline that moms get when they're delivering. And it also can be related to the type of medications they're receiving with the epidural. They'll have the shivers. So comfort measures for chills. We want to offer them a warm blanket. Even though it's not really related to cold, it helps kind of reduce that feeling. Maybe even offer warm drinks, so some warm broth, warm tea, warm coffee. You're going to reassure it's normal, okay? A lot of people, if they've never had a baby or if they've never seen someone have a baby and they're like shivering, they're thinking, oh my gosh, I'm going to sneeze or something, you know, and you're like, nope, that's normal. We're good. And it only lasts a short while. It usually is gone within 30 minutes after delivery. So our vital signs, we're going to see our temperature change. It's going to go up a little bit. You're going to see a little low-grade fever. Okay, 100.4 can be normal. And this is because it's a result of that exertion from delivery and possible a little bit of dehydration. Okay. And it's also your body temperature rises as your body starts to heal. Okay, when your body's producing those white blood cells, your temperature rises a little bit. It's fighting off any bacteria that may have gotten to that placental side or to that laceration side. It doesn't necessarily mean there's an infection already. It's just your body's response to try to get rid of that bacteria that's there. Okay. Your blood pressure is going to have a transient rise. You're going to possibly have some orthostatic hypotension. You're going to have some bradycardia, and we've got to watch for hypertension. Okay, let's take a 20-minute break. We'll come back at 10:10, and we'll finish the lecture. Okay.
You posted a game yesterday, but that was totally.
That was the fetal freedom, yeah. Okay, so let's talk about blood values. So again, remember when a woman is pregnant, her WBCs can be slightly elevated, okay? And this is just due to her body's going through changes. It's trying to continually fight off anything that could possibly cause harm to baby. And so it's gonna have a rise, okay? Postpartum, it's gonna rise even more. And again, as part of that healing process, you're gonna have healing around that placental site. And so as that occurs, you're gonna have your WBCs go up again, okay? So anywhere between 25 to 30,000 is normal. It should return back to normal by the end of the first postpartum week. Coagulation factors, these are activated during the pregnancy. So you may see a higher platelet count, but these will go back to normal after delivery, about 3 to 4 days. You may see some change in blood values due to trauma during delivery. So like there are some blood, if we were to do like a CPK that tests for like inflammation, that would be elevated. And the reason is because you just had trauma, okay? Muscles was torn, muscles were used, and so it's gonna be elevated, but we usually don't test for that, okay? Immobility, okay? So you're gonna see with immobility, this is gonna increase some of your blood values, especially like with coagulation, because the woman's not gonna be moving as much. So we do encourage her to move. We don't wanna cause those clotting factors to then gather together and cause a DVT. Fibrinogen will return to normal. So your risk for embolism for the first 6 weeks is pretty high still, because those deep veins are continue to still be dilated in diameter. So what can we do? What are some interventions we can encourage to help reduce this risk?
Elevated legs.
Elevated legs, movement.
Walking,
Not walking. If she's walking but not walking, what is something we can have her do while she's sitting?
The little.
Head holds.
leg exercise,
What kind of exercise, Marisol?
leg exercise.
Leg exercise, foot pumps. Okay, she does foot pumps, kind of like you're pushing on a gas pedal.
What
Off
about
and
the
on?
leg braces that,
The what?
the leg braces for the DVT?
Are you talking about like the Flotrons or SCDs? Okay, those you actually can purchase on Amazon. Anybody knew? And they're not actually very expensive. They have some battery operated ones. Really surprised about this. So yes, if you want to invest in some, yeah, that would be great to have at home, you know. But if not, you can do those leg pumps. Get up and move as much as possible. Stay hydrated, you know. Elevate your legs when you are lying down to help reduce the inflammation, because with inflammation, that's going to put constriction, and that's going to cause a risk too.
Should they reduce like their sodium intake with that?
It might help a little bit, but because of the fluid shift, it's not really related to sodium. It's just related to that blood volume going back.
Eat like celery, like diuretic.
I mean, yeah, but it's still, your body is trying to get rid of it, and you're going to get rid of it as fast as your body can. I mean, even taking diuretics not going to, it's just going to make you pee more.
What about like a baby aspirin?
Depending on the person, there are some people that if they're at higher risk, like say they're obese, older, or have other comorbidities, they may recommend them take a baby aspirin to help reduce that, to just with the coagulation factors. Gastrointestinal changes. So a woman is going to be hungry after she has a baby. Right?
Even if we're not pregnant.
Yeah, that's very molecular. And the reason is it's usually because your body naturally expects you to breastfeed. Okay, that's our body's natural thing. We need to make milk. We're gonna make milk and give nutrition to baby. Mom needs to eat, right? And so your body's natural response is to be hungry, because we need to now just like we were pregnant, we needed to have that extra few calories. We still need to kind of have those extra few calories whenever we are breastfeeding. You may be thirsty due to loss of fluids during labor. Okay. Plus 2, when you breastfeed, you just tend to be thirsty because your body needs more hydration because you're making hydration for that baby. So you're going to want to drink water, water, water. Okay. Mobility sometimes will be decreased and you're going to have some constipation. This is due to lingering effects of the progesterone and that decreased muscle tone. Okay, so you may have some constipation. Your bowels aren't going to move as well post-delivery. Plus, that first bowel movement. It does suck.
Do you get it like after delivery or just like days off after delivery?
What?
First of all.
It just depends on the person. Some people can have their first bowel movement that day. Some people may take a couple days. But it usually is very uncomfortable because you have lots of inflammation in that area of the body. Probably have some hemorrhoids, so it's usually not the most fun if you have a laceration or an episiotomy. Yeah, not fun. And even with a C-section, because then you're not just affecting the perineal area, but you have an incision in your abdomen. And when you have to bear down to poop, you're going to use those muscles. So either way, it's going to be uncomfortable.
So you take that
Not
cost.
supposed to.
Colace, and then what do you say?
Yeah, you're not supposed to force.
Right. We encourage you to just let it naturally happen. But of course, sometimes you got to have a little bit of extra force behind it. But yes, Colace. If you're taking narcotics like hydrocodone, Percocet, you want to encourage your patient to take a Colace. Okay, they can take up to 2 a day, 1 in the morning, 1 in the afternoon. Increase their fiber in their diet. If they can't increase their fiber, they can do like FiberCon or a fiber pill. Okay, to just help encourage those bowels to continue to move. Laxatives are a no-go, especially if you're breastfeeding. Cesareans may advance their diet is tolerated. So they're initially going to be on clear liquids when they first, after the surgery. Once they tolerate those, then you can advance it to, on a surgical floor, if you have a patient who has had surgery, you're going to advance it a little slower. In labor and delivery, if mom can tolerate clear liquids and then she can tolerate some pudding, usually I'm going to go ahead and order her a tray because she's going to be hungry. Okay. And she needs that sustenance for energy to help care for baby, and then also if she's breastfeeding. Okay, if they seem to tolerate well with those liquids and maybe a pudding or 2 and maybe some crackers, give her a tray or have her family go get whatever she wants. Okay, because she needs to eat. And again, pain medicines with them are definitely going to slow those bowels because they're going to be on a higher dose narcotic because of the incision. So you want to really encourage them to move. Okay, a lot of them don't want to move, but with surgery, what you have to explain to your patient is the more you move, the better you feel, the less pain you have. A lot of times in their brain, that doesn't make sense. When I move, it hurts. Okay. Yes, it hurts initially, but the more you move, now I tell them exact words. I tell all my patients, I don't expect you to run a marathon. Okay. I just need them to be up going to the bathroom. I need them to be up getting the baby out of the bed. Because if you just lay there and do nothing, you're going to be at risk for DVTs. That pain's going to get worse when you do initially move. You're going to be stiff, sore, okay? And you're doing yourself no good. Your body is going to heal slower than if you were up moving. Urinary tract. So if they have anesthesia like an epidural, or they have a C-section and they have a spinal, that anesthesia is going to inhibit the neural function of that bladder. Okay, so these patients are at big risk for bladder distension or unable to go void because they have that medication still on board. So of course, with the C-section, they're going to come back with a Foley catheter. We're going to remove that catheter once they start having more sensation in their legs and feet. Okay, you don't want to wait till they can fully move because we want to have that bladder start to feel a little bit. So that way, when they can get up and move, they can actually empty their bladder and void because we need the body to start responding. Excuse me. And so You don't want to wait till right before you're about to get them up to go to the bathroom to remove the catheter, because is their bladder going to be full? No, it's going to be drained because it had the catheter in place. Okay, so we remove it at least an hour and a half before we anticipate we're probably going to get her up. That allows for that bladder to fill a little bit, and then she's able to actually go urinate. Okay, because we need her body to actually react. Okay. If they had an epidural and a C-section, we usually wait 2 hours post-delivery before we even try to get them up. Okay, and the reason this is one, the anesthesia has to wear off, and even if they didn't have any anesthesia, we don't want them to pass out. Okay, they're at a bigger risk of having that orthostatic hypertension right after delivery. So we want to let their body kind of recover for a little bit. So 2 hours while you're doing those fundal rubs, we don't want to get them out of bed. We want, if they have to use the bathroom, we're going to put a bedpan underneath them, have them pee in that. Once that 2 hours has passed, then we're going to get them up. Okay. Sometimes if your patient seems to be doing really well, we might even offer them to do like a quick rinse off shower. But you have to be really careful, because what is warm water going to do? It's going to relax you. It's going to cause vasodilation. Then what's going to happen? Okay. I've taken a shower a few times with my patient. Okay. Because they look really good. I'm like, oh, they're doing great. You can take a real quick shower, but I stay, one nurse stays in the bathroom with them. The other nurse is in the room doing the bed. And, she was like, oh, I'm starting to kind of feel lightheaded. So I'm about to, I'm opening the curtain, about to get the water turned off, and she starts doing this. So I have to go in. Okay. So we both took a shower. Our little showers have seats in them. So we got her to the seat. We all grab our little ammonia out of our pocket, pop it, put it in their nose, and they're all like, whoa, what's going on? Okay. And you're going like, whoa, what's going on? Because it's coming to your face too. And then it's always that initial, like, they just look like they're in another world initially. Like their eyes are like, where am I? And then they come back and they're like, oh, what happened? Like, oh, you just passed out a bit. Okay. You gotta be positive. And then so us being creative labor and delivery nurses, a big wheelchair is not gonna fit in there. So we'll usually go grab one of our little wheelchairs like this, a wheelie chair, throw a pad and a towel over it, stick them on that, wheel them over to the bed, and then put them in, So you just have to be cautious when you do get them up, because there's big potential that they could pass out. So that's why we usually have 2 nurses in the room. That way, as they're going to the bathroom, we're both kind of there with them. Once they sit down, one will go about cleaning up the room and making the bed, while the other one is with the patient the whole time. Okay. So you gotta be cautious getting them up to the bathroom. So stretching and trauma due to swelling and bruising of the tissue around that urethra during delivery may cause them to not be able to void immediately. So again, that's when we're gonna do like the spray. We're gonna do an ice pack to help reduce that swelling so she can't pee. This can lead to over distension and possibly cause residual urine. So if they have residual urine, does anybody know what that means?
They're not empty.
They're not emptying completely, so they void, but there's still residual urine there. So if you have constantly residual urine staying, what's our risk? UTI, because we have this pool that can get bacteria in it that then can grow and cause a urinary tract infection. If they're not able to void, yes, you want to go ahead and empty that bladder completely until they get that swelling down or they have that sensation back. So what's another risk if we have over distension? If our bladder is located where? Right up against our uterus, right? Okay, it's actually kind of adhered to it. So if our bladder starts to fill up, where does our uterus go? Up. Okay, it goes high and usually to the right. And if you have someone who already had some difficulty maybe firming up, if it keeps pushing that bladder higher and higher and it doesn't allow it to tramp down as much as it needs to, what's your risk? Bleeding. Okay, if the uterus can't go down, can't cramp down as far as it needs to because the bladder's full that's attached to it, then you're going to notice more bleeding, heavier bleeding. That's why another reason we don't want to cause over distension. So they're also going to have puerperal diuresis. This is that fluid shift from blood to water. 2,000 to 3,000 ml. Pretty crazy, huh? Think about those liter bags, how much you're gonna pee out in the next 2 to 3 days. Bladder rupture, it is a potential. Like if you are not paying any attention to it, you could cause a tear in that bladder.
If the patient feeling something before it.
Well, they're gonna feel very, if their anesthesia is worn off, yeah, they're gonna feel the pressure and the sensation. And of course, remember, not everybody, I mean, we have an idea about how much a bladder can hold, but everybody's a little bit different, you know, so we can't just say, oh, you know, her bladder can hold a lot, we'll just think go pee later. You know, if she starts to complain about needing to go to the bathroom, we need to do an intervention. So what's one way we can tell how much is in that bladder? Palpating, and what else? What's that called? Like a sonogram. Bladder scanner. Yes. There's one over on the surgical side. Go grab it, stick it on the tummy, and see how much urine's in there. Okay. If you have more than about 500 to 600, then you probably need to have her pee or try to straight catheter. Okay. We got to teach some peri-care. Okay. So if a lady has a laceration, or she had to have an episiotomy and she has sutures there, and then we have a pad in place, it's a dark, moist area. What's our risk? Infection. Right. We have a great place for bacteria to flourish and grow. So you want to encourage your patient to change her pad every time she goes to the bathroom. She should use that peri bottle to rinse the area well, pat to dry, and then use that Dermoplast spray. Because it's not only got to have lidocaine in it, but it has an antibacterial in it to help reduce the growth of bacteria and heal. Okay. So teach good peri-care because you want to allow that laceration to heal. And so they've got to kind of clean it. It's an incision, it's a wound. So they have to take care of it just like if it was on their arm or leg. Okay. But in this area, they have a greater risk of infection because it is a moist, dark place. The bacteria is going to have a lot of room to grow. Neurologic. So a lot of time women can have headaches, and there are several reasons. So if anesthesia or analgesia, does anybody know what that headache is called that potentially could happen if you have like a C-section? Called a spinal headache. So if they have pierced through that dura and they go into the spinal column itself, what happens is it should over time after the spinal has happened, the body should kind of form like a little seal over it naturally and allow that spinal fluid to stop leaking out. Well, of course, you know, a mom, they just had a baby, they got to get up and go to the bathroom, they're taking care of baby. Well, when that happens, sometimes that can cause that little seal that has formed to open back up. And so if that opens back up, the spinal fluid can leak out. And if spinal fluid leaks out, it causes a very severe headache. It's called a spinal headache. Very simple to fix, okay? Anesthesia has to come back. So they're going to do what's called a blood patch. So they're going to set them up just like they would for a labor epidural. The nurse is going to draw 20 cc's of blood from a vessel in the mom, so usually the AC, because you're just going to draw blood when the anesthesiologist tells you to. And then you're going to hand it to them, and they're going to basically do a spinal. They're going to put the needle back in, but then they're going to put that blood in that area and do what's called a blood patch. Okay. So what's going to happen to that blood? It's going to coagulate, and it's going to form a natural seal over that area of the spinal column. And your patient is almost going to have an immediate relief. Pretty crazy how fast it happens. Okay. Now with the spinal headache, it just depends. Sometimes they're going to first have the patient just lie still for several hours and just see if the body can naturally close back off again. When I had my son David, he was born on a Monday. When my anesthesiologist or CRNA Mark did my epidural, he pierced through the dura on accident. Okay, and he told me, he's like, the epidural catheter went into the dura, but I pulled it back. He said, just let me know. So if you get a headache, let me know. Well, I have a history of really bad migraines, and you know, when you're an adult and you have migraines, what do? go to work. You work through your migraine unless you can't see because you have so many floaties. You just have to work through the thing. So the next day, my head was hurting really bad. I'd taken pain medicine, and so I finally told my nurse, I was like, hey, can you call Mark? I think I have a spinal headache. So he comes in and he's sitting there talking to me. I'm sitting up in bed. He's like, hey, I don't know, you're sitting up in bed. I really don't think it's a spinal headache. I just think it's from delivery. And my blood pressure was good. I was like, okay, that's fine, you know. He said, just rest. So I did. My mom was there, so she was there to help me. I did, you know, had to still get up and move and stuff, but minimal as much as I had to do because I had family there. Well, my grandfather got real sick on Wednesday, so my mom left early. She was going to stay all week, but she left early. He ended up passing away Thursday night into Friday morning. And so I got the call early Friday morning from my mom that he had passed away. And it was expected, but kind of sudden. You know, we've been sick. So my son had a doctor's appointment that day for his follow-up after delivery. And so I said, well, we have doctor's appointment this morning, but we'll get everything packed up. And as soon as we're done there, we'll head that way. So I got into a car. It was 3.5 hours from where my parents lived. Got in the car, drove in the car, got to the house, you know, loaded bags, unloaded bags, loaded baby, unloaded baby. So by the time I got to my mom's house, I could barely eat. My head hurt so bad. I had a spinal headache. Well, I'm 3.5 hours away from my provider, and I don't want to go to the hospital there. So I literally laid in bed for 2 days, drank tons and tons of Coca-Cola because caffeine will help, and didn't move. My husband would bring the baby to me so I could nurse him when he was hungry, and then I would go back to sleep. And it took about 2 days before I could actually sit up because the pain was so bad in my head. Okay. So spinal headaches, if your patient tells you that it's a really bad headache and their blood pressure is normal, everything else is normal, but they've had an epidural or they had a C-section, then you've got to consider, do they have a spinal headache, and notify anesthesia to come in and evaluate. Okay. It's a bad, bad, bad headache if you've ever had one. Okay. So the other thing we've got to look at with the headache is hypertension, because I told you again, we could possibly have postpartum preeclampsia. Does anybody know the 3 or 4 common symptoms of preeclampsia? Swelling, headache, protein in your urine.
High blood pressure.
I got the high blood pressure. Seizure is going to be with eclampsia, so preeclampsia. Visual changes, okay. Dizziness possibly. And so when I say visual changes, used to we would say, you know, ask a patient if they had blurry vision, okay. So I don't specifically give them a description. I say, have you had any changes in your vision? Because if I ask you, do you have blurry vision? You're going to go, yeah, all the time. Maybe I do have blurry vision. Do you have blurry vision? You know, and so you just say any changes in your vision. Like, oh yeah, I kind of see little sparkles or stars, because everybody's going to describe it a little bit different. And it may be a little bit different what they see versus someone else. Okay. So changes in vision, and then the epigastric pain. Okay. Right under the right breast. So I always say, do you have any pain under that right breast? Because that's the liver. The liver's inflamed, it's going to hurt. And that means we're progressed pretty far and we possibly are getting close to eclampsia. The liver's already involved. Okay. So sometimes the headache can be related to hormone changes. Okay. A drop in estrogen, you've had this really high amount of estrogen and progesterone, and all of a sudden now you have a drop. Okay. Just like when you have your period, a lot of women have headaches with their period because what's happened? You've had a drop in progesterone, a drop in estrogen, you're having a period. So PMS, a lot of people have headaches. Okay. If they have a history of seizures, they do have a history of having a seizure postpartum just because of all the extra stress on the body. Of course, seizures are also a risk for preeclampsia, so we've got to be careful. So women diagnosed with epilepsy are 9 times more likely to have a seizure during labor or the first 24 hours postpartum. Okay, so if they have a history of seizures, you've got to be very cautious and be aware of that. Okay, again, it's due to stress on the body. Increased symptoms from pre-pregnancy disorders. So if they have epilepsy, depression, a history of Guillain-Barré syndrome, multiple sclerosis, or any kind of autoimmune diseases, because of the trauma that goes along with delivery to the body, you can cause flare-ups in these diseases and disorders. other stuff to think of. So initial weight loss is about 10 to 12 pounds from birth of the infant, placenta, and your amniotic fluid. Okay, so think about how much the baby weighed. An 8-pound baby, your placenta was about 1.5 pounds, 2 pounds. Okay, and then whatever amniotic fluid was there. Plus, you're gonna have that puerperal diuresis. Okay, so you're gonna lose that volume of blood that you had. That's gonna be about a 5-pound weight loss. And then 60 weeks, the remainder of the weight loss is if you have gained any that is above average. So any adipose tissue that your body added on. Now, I'm not sure how accurate this is, because I'm like, I don't know that much over athletic. But I did eat a lot right after. Well, I was hungry.
Does this include regular or also cesarean?
Yeah, both. This is both. Okay. So again, with those contractions or after pains, cramping, more babies or more cramping. Breastfeeding, more cramping. Okay. So now we're going to talk about the psychological changes. Okay. So there's 2 different phases that Mr. Rubin, whoever he is, decided there was. So that taking in phase, that's right after delivery. Okay. So this is not a good time to try to educate right after delivery, because this mom's probably not going to remember. Okay. She's got all that adrenaline. She's just super happy. There's a lot of stuff going on. So this is not a good time to try to educate in those first few hours post-delivery. They are very passive and dependent. They can't sometimes make decisions. Sometimes they're preoccupied with her needs and not the baby anymore, because it's like, oh my gosh, everything has happened to me. Like that, my mom who had a 9-pound baby initially right after delivery, what did she do? She fell asleep. She could care less about seeing that baby. But I can understand. She's gone through a whole lot, you know. They may not remember that labor and delivery process. A lot of women who choose to have drug-free deliveries will tell you that sometimes it seems like it's surreal, like they kind of had like an out-of-body experience, because the pain is so intense that they really don't even remember the process of delivering because it was so intense.
What's their reasoning to not use?
Don't ask me, okay? Because I've had 4 vaginal deliveries. My son, my third one, I was telling you about my spinal headache. I was going really fast, so my friend Mark, who was my anesthesiologist or CRNA, didn't put me on a pump to continuously pump medicine in my epidural because I was going really fast. I was like, okay, that's fine. He's like, you'll have a baby the next hour by then. You know, all the medicine I gave you will be close to wearing off, and then he'll be here. Like, sure, that's fine, no big deal. Well, what we didn't know is he was he was looking up instead of down. So it took me longer to fish him out. So by the time I delivered him, I felt everything. And I thought to myself, why in the world would anybody choose to do this? But they do. To each their own. Okay. But a lot of times you'll talk to those people who have had pain med-free deliveries, and they'll tell you that it's very surreal, like because you're in such intense pain at the delivery phase.
I had the epidural in my second, my third and fourth. I didn't have anything medication, but it went better.
Really?
I mean, of course, I've already had.
Right. You had been there and you kind of knew what to
Yeah,
expect. Yeah.
but I just like, I don't know, like the compressions were more effective for me
Right.
without any.
Right. And so, yeah, everybody's different. And plus, everybody's body tolerates pain differently. You know, I was what we would refer to whenever I worked in Dallas, a WWW. I was a whiny white woman. Okay. I screamed my head off. My husband told me to calm down, and I twisted my head around and vomited 2 times and looked at him and said, don't say that to me. He said I look like the Exorcist. And it was because, oh my God. And so when I said I was never having any more children after that, I was like, no, we're not ever doing that again. So then when I had JC, my youngest, my 5-year-old, When I got to the hospital, I was actually in labor. I was being induced, but I was in labor. And they checked me and I was 5 to 6 centimeters. And I said, okay, everybody stop right there. Before we do anything else, I want my epidural and I want a pump and I want a bun. So I could push my own med, you know. And so I did. And so I did not feel safe. It was wonderful. But some people choose to go ahead and do without pain medication. And like I said, to each their own. I can't do it, but some people can. Some people do a great job at it. You know, I have a cousin who had every delivery without anything. Me and my mother-in-law had 5 kids without anything. Crazy lady. So that initial period, though, that taking in, even with someone who has had pain medication, the focus is so focused on what's going on then, that new baby, that new situation. So they're not going to listen to anything you say, okay? Even though you might tell them some stuff, they're not going to remember. So then we want to do during the taking hold. So this is usually after that first kind of initial first day, that first 24 hours, it's not a really good time. Okay, so second and third day is when you're really going to want to go ahead and start doing your education. Okay. So with the taking hold period, that's when she's ready to resume back to kind of her normal life. You can do a lot of education, breastfeeding education, postpartum education, what they need to do, how to take care of their body, nutrition, continue those prenatal vitamins. They still need the iron because now they've lost blood, so we need to build that back up. The maternal role of attainment or becoming a mother. Okay, so bam, they become a mother. Okay, and it is like bam, kind of hit you in the face. Okay. I think sometimes people don't realize that, you know, they're so excited about the delivery and that's all they're anticipating, that they, you know, they kind of are prepared because they've got everything they need to go home, but they don't think about what it's going to be like when they get home. Okay. Now you have this new little baby that's going to cry for food every 2 to 3 hours, who's going to have their pants changed every hour to 2 hours, who sometimes will sleep well, sometimes won't. You know, and so all of a sudden, you know, you've gone through this long labor process, you're super tired, and now you've got something that needs you all the time. So does that tiredness and super sleepiness go away? Oh no, it gets maxed out. Okay. So the process in which a woman learns mothering behaviors and growing in her identity, that's this initial time after. Okay, this is kind of when you figure out all these things I read about, or all these things people have told me I need to do or don't do. This is when I decide how I'm going to do it. Okay. And there's no right way. There's lots of different ways to mother and be a parent. There's no right way. Okay. But we have to make our own way, figure out what's best for us and our family. So this identity starts to really grow about 3 to 10 months post-delivery. So the first initial few months is kind of learning, figuring out. Once they get to that routine starts. Okay. So the transition process of becoming a mother. So you're going to be able to give them instructions about infant care, promoting maternal infant bonding. And again, it's going to, sometimes if you have like your young moms, there's a lot of places, which I wish we had it out here, which we don't. When I worked in Tulsa, we had a program for first-time moms, just if they were young moms, where a nurse would go into the home once a week and continue that education. You know, continue assessment. How's it going? What's going on? How's baby eating? What's the baby's weight? They would weigh the baby. They would measure the baby. And then that way they could kind of follow up with these young moms who maybe, you know, one, they're new moms, but they're also very young, to kind of help with that process. So, you know, and even sometimes older moms, you need that extra help, you know, why they always say it takes a village. Family bonding. Okay. So this is just some phases that they've broken down when it comes to family bonding. So the fingertip enfolding. So this proceeds from fingertip exploration of the newborn's extremity, then palmar contact with the larger body areas, and then enfolding the infant into the arms, or hands and arms. So this is like the new parent exploring that baby. Think about when you first had your baby, you looked at everything, right? You looked at the toes, you looked at the toenails, you looked at the fingers, you looked at everything. You say, oh, they have this looks like grandma, or, you know, you explore every inch of their little body. Okay, that's what this is talking about. This is that fingertip enfolding. In-face position, so this is that direct face-to-face eye contact with the infant. You know, that just looking them in the face when they do open their eyes. And I like to always, after delivery, I'll dim the lights real low so that baby will then start to open their eyes and they can actually see. And everybody wants to know what color their eyes are. Okay. And what I have to tell them is every baby has dark gray blue eyes when they're born. Every baby. And then over time, the next few weeks to months, even sometimes up to a year, because my daughter had blue eyes over a year old, and then they turn hazel. It's going to change a little bit. Okay. And so, but every baby has like a dark gray blue eye color, and then it changes based upon genetics. Goal in reciprocity. So this occurs simultaneously between the mother and the infant. It's kind of that mutual cooing behavior, expectancy, synchrony. Okay, so that's the mom really bonding with that baby, all that little baby talk we do to them. Okay. So then father's engrossment. This is similar to mother's attachment and feelings. This is that dad developing those feelings. You know, moms had almost 10 months to feel that baby, to attach to that baby. Even though they couldn't physically see them, that baby was there with them, right? Now it's dad's turn, okay? You're going to see this man that's strong, hard, don't do anything, sweet man turn into this little puppy lover, you know? And you're like, who is that? Okay? And my husband's still that way with my 5-year-old. It's so funny. Siblings and others. So you're going to see strong attachment as well. Again, before COVID, our hospital settings had gotten more and more family friendly. So where siblings could be there, pretty much anybody you wanted could be there as long as it wasn't high risk. But now with COVID, we've gone down to where most places only allow 1 to 2 visitors. Okay. And we know the reasoning is because we're trying to reduce that risk to mom, baby, and then everyone else in the facility. So that has changed that family dynamic within the birthing process a lot. Postpartum blues, okay? This is very common. It occurs within the first few days, should last about 10 to 14 days. The causes is changes in hormones, sometimes lack of support, insecurity about who they are and how they're going to do this. Fatigue, that's a big player in this. They're just really tired, okay? Overstimulation or discomfort. So symptoms you're going to see is mood swings, anger, weepiness, anorexia, or difficulty sleeping. They should be evaluated if it persists or worsens, okay? So postpartum depression, usually they don't diagnose until after week 2 to 3, but sometimes you can actually see those symptoms prior to that 2nd week. So postpartum depression is way different than like clinical depression. Okay, does anybody know much about postpartum depression? You had it? I had it with my last baby. Okay. So you would think with my first son, my son that was stillborn, that I probably would have gone through it, right? Because the traumatic time in my life. Okay. Now I had clinical depression post-delivery, but I didn't have postpartum depression. It's totally different. So with postpartum depression, the most common first symptom women feel or have is you start having very odd thoughts. Okay. Can be about hurting yourself, hurting the baby, hurting your husband, hurting your other children. Okay. This could be physical harm, mental harm, sexual harm. Okay. Very scary. So I knew I had postpartum depression when my daughter was about 8 days old, 7 to 8 days old. And I was trying to get her to breastfeed. She wouldn't breastfeed, so I was pumping. So, you know, I was getting very little sleep. I was up every hour to pump and then feed her again and then go through the whole process, sleep for an hour, do it all over again. I was worn out. I was tired. I was determined I was going to breastfeed. And it was the middle of the night and I'm awake, getting her ready to feed. and I pumped the bottle, and all of a sudden I had this crazy thought cross my brain. And I'm like, oh my gosh, why did that cross my brain? So I got scared, but I knew what it was because I'm a nurse. I worked in the clinic setting. I've educated lots of patients on what they need to look for with postpartum depression. So it took me about 2 days to finally tell my husband what was going on, because he was about to leave to go back to do his job, which was a college minister at the time in Tulsa. So he was going to teach his first Bible study in the evening since we had JC. And I said, you can't leave. He was like, why not? So then I told him, I'm having these crazy thoughts. Well, it scared him, because he's not a medical personnel, so it scared him. So he calls my mom. Well, my brother-in-law was having major surgery the next day to remove the Crohn's disease from his colon and redissect his colon. So my mom was at my sister's house to keep the kid. So a couple hours later, my mom shows up at my house with my niece and my nephew she had taken to his other grandparents. And so my mom stayed with me that first week, and my sister kept calling and saying, you should go to a counselor. Why don't you go to a counselor? And I started on some medication because I knew what it was. And I finally gave in and I went to a counselor. And so when we left to go to talk to this woman, and she was a Christian counselor and she specialized in postpartum depression, I felt like when I left there that I probably was never going to see my kids again. Because I was like, if I go tell this person what is in my brain and what my brain is thinking, they're going to take my kids away from me. Okay. But I went in and I talked to her and I told her what was going on. And she said, you have postpartum depression. I was like, well, I know that, but then she tells me, and it's okay. And I just had this enormous relief. Okay. So I went to counseling for about 6 weeks and was on my medicine. And it took almost 2 years for the postpartum depression to completely go away. Okay. Now, it wasn't until I realized one day, it was like, oh my gosh, I haven't had a crazy thought in about 4 weeks. It's gone. Okay. Because it just became kind of a normal part of my life. And what she gave me the tools that I needed to remind myself that it's not real. It's just my brain. Redirect my thoughts to something else. Okay. So postpartum depression is very scary because it's not just, oh, you have these feelings of sadness, you want to sleep all the time, or you have insomnia, you don't want to do anything. Your body literally creates crazy thoughts about people you love. Okay. And so that's why, unfortunately, you see reports in the news about young women who have hurt their child, have hurt their other children. Okay. And usually the youngest is under the age of 1. Okay. So if you go and look at reports, the one that everybody knows is the Amy whatever from the 90s who drowned all her children. Okay. She had a 9-month-old. And she said, I just had to do it. Because she went into what's called postpartum psychosis. So that depression can then progress into psychosis. And that's what I was afraid I was going into, because I was like, these are just the craziest thoughts ever. And my counselor thankfully said, Amanda, you know those thoughts are wrong. So you're not in psychosis because you're coming here because you know those are wrong. When you get into psychosis that you don't understand and realize those thoughts are no longer wrong and you act on them. Okay.
Like that girl, like that 18-year-old that just stuck their born into the trash can. Would that then like postpartum or?
Well, if it's a newborn, I think sometimes, okay. So there is antepartum depression and antepartum psychosis that can occur too. Not as common as the postpartum depression and psychosis, but when you have a newborn like that, usually it can be related possibly to other mental health issues that she had prior to, did she have schizophrenia? Was she bipolar? Or maybe she was just scared. Okay. That doesn't necessarily mean that it was related to postpartum depression with a newborn, because usually you don't see that progress until a few weeks to 2 weeks after delivery, unless she did have the antepartum depression and psychosis, which can happen. Not common, but it can happen. So just remember that as a nurse, sometimes, like I said, you're not only just taking care of those physical needs that that person has, you are also having to look at and assess those psychological needs. Okay. So it can be very challenging having a newborn. Okay. So we've got to do lots of education. We give lots of support. We make sure they have that support when they leave. Okay. So when we do quiz, the difference between postpartum blues and postpartum depression is postpartum depression is similar but lasts longer and more severe. Postpartum depression is resolved faster than the blues. Mother just tries more with depression due to the hormones, or the hormones have nothing to do with either blues or depression. It's a tough one. First one. So postpartum depression is similar, but usually lasts longer and is more severe. Okay. You still have those ups and downs, but the difference is those feelings and thoughts that you have. Okay. Ooh. Okay. So when you're doing a postpartum assessment, this is an acronym that's going to help you know what you need to assess. Has anybody ever heard of bubble HE? Okay. So bubble HE stands for breast, uterus, bowel and bladder, lochia, episiotomy or laceration, okay, Homan signs and hemorrhoids, and emotion. Very important to know. So when you're going in to do a postpartum assessment, think about these things, okay? Besides your typical assessment that you do on anybody else, head to toe, you need to assess the breast, okay? Assess that uterus. Where's that fundus? How much bleeding is going on? Bowel and bladder. Has she had a bowel movement? Is she able to void? Is she having discomfort with voiding or having a bowel movement? How much bleeding does she have? Or lochia? How does that laceration or episiotomy look? Is it well approximated? Which is, what do we look at when we're assessing that? What's our other term? Rita, redness, ecchymosis, erythema, drainage, approximation. Okay. And then Homan signs, and remember that's where we're checking the cap, and hemorrhoids, and emotion. So for nursing care with our breasts, we want to provide nipple cream if they're breastfeeding. You want to give lanolin cream. Lanolin cream is all natural and it does not have to be washed off before she breastfeeds again. So it has to be 100% lanolin. There are some breast creams that are not 100% lanolin and that her nipples will need to be washed before she breastfeeds. Okay. So with lanolin, you don't have to. You want to make sure the proper latching of the baby and unlatching. Okay. Teach them the pinky trick. They want to put their pinky kind of at the corner of the baby's mouth to release the suction. So that way they're just not popping the baby off. Okay. You're going to look at the BSE. What did I make BSE? Let's move on because I don't remember what I yeah, it is something with breast. I'll look it up in a second. Engorgement. If they're not breastfeeding, then yes, you want to do the tight bra. Even with breastfeeding, you can still do some ice packs just to help reduce the inflammation. And then you want to get that baby onto nurse. Okay. Breastfeed. Now, if they're pumping to feed, that's fine too. But we don't want to breastfeed and pump to reduce the amount because remember, what are we doing? We're triggering the body to make more. Okay.
Breast self-exam.
Thank you. We'll have to look
Well, I
it up.
looked it up.
Oh.
No.
I bet that's it. Breast self-exam. Yes. Because we're looking for mastitis. With mastitis, they may have to be on antibiotics. And again, do they have to stop breastfeeding? No. As long as we make sure it's a safe medication for baby. Okay. Oh, quiz. In the acronym, Bubble heat, L stands for should have given y'all this much time on the other one. Correct, Lokia. Okay. Okay, so the uterus, again, we're gonna massage every 15 minutes for 2 hours. Then you're gonna assess every 30 minutes times 2, then every 4 hours. This is what the recommendation by your textbook is. Okay, this is the information your textbook gives. Now, every policy may be different for your facility, so you need to assess your facility policy. Okay. We're looking for acne. What's acne? Not firm. It's bobbed. Okay. We're looking to see if that muscle is loose. That's acne. Bleeding. How heavy is the bleeding? So don't just look between the legs. You also need to look under her buttocks and hips, because if she's bleeding and it's flowing underneath, she could have a huge pool of blood there, but nothing in between the legs and lower. And like, oh, she's not bleeding at all. She's hemorrhaging, but it's underneath her. Okay. Where to find the fundus immediately after? So this is true. It goes down about U minus 5. Okay, but I don't want to confuse you guys. Okay, because I always find out this confuses you guys. We are worried more so about that being right at the umbilicus or a little below. Okay. Because initially, as soon as that placenta comes out, it drops all the way down to the pelvic floor or to the pelvis bone, but then it comes back up. Okay. So when you first feel, it's probably going to be a little lower, but we always expect it to rise back to that U. Okay. That's where what I want you to remember. We expect from that point on, every time that we massage, it should be at U or minus 1. Okay. Then it decreases 1 centimeter every day.
Do you tell them to check it?
I do. I encourage my patients to do fundal massages in between knee rubbing, because especially if they've had 3 or 4 babies, because I just tell them, if you kind of consistently check it and make sure it's nice and firm, when I come in and check it, I'm not going to have to do any aggressive rubbing. Okay. The other thing is we have to consider with this is if they've had a C-section. Okay. If they've had a C-section, we're still going to assess the firmness, but unless there's some active bleeding, you do not want to do a vigorous rub. Why? Right, you have an incision on that uterus that's sutured together that you could easily make come apart. Okay, so you do have to be cautious when you're doing a C-section rub. You want to feel, make sure it's firm. If you're not firm, gently massage. The only time you're going to get aggressive and do an aggressive rub is if they're actively hemorrhaging or bleeding. Okay, because we don't want to open back up that incision.
And how soon after the C-section do you check?
You're doing the same thing as you do for a postpartum vaginal delivery. You're going to assess every 15 minutes for 2 hours. Bowel and bladder. Okay. They may not have a bowel movement until they go home. So we teach them about, making sure they possibly do stool softener, lots of water intake. The first one's probably going to be uncomfortable. They can do like a glycerin suppository. The only thing is we just do not want to do any laxatives. Okay. They can even do a fleet enema if they need to. Okay. So we have to do some education on what they can do. Bladder distension can cause acne. Again, if that bladder's full, that uterus can't contract down and you're going to have some bleeding. So we're usually going to measure the first 3 voids and then just as needed. We want to make sure that her body's diuresing and that she's able to actually pee. Okay. We want to see at least 200 or more in that cat. And you're going to see it's going to be red. You may even see some little clots in there, and that's just from her bleeding.
Why not laxatives?
One is because we don't want to irritate the bowels. Okay. And plus, if they're breastfeeding, we don't want to give a laxative to the baby.
Oh,
Because if they're breastfeeding, it's gonna cross the breast milk. They have hemorrhoids, we're gonna use Cups Pad, Sitz Bath, the spray. The lochia, if they're saturating a pad every hour, it's too much. Our fundal massage is always the first intervention. If they have heavier bleeding, we're gonna check that fundus and rub it. Weigh your pads, 1 gram equals 1 ml or 1 cc. Nothing in the vagina, no tampons, especially for the bleeding. We need to let it come out. And we don't want to have something there that bacteria can grow in. It's going to have a fleshy odor. It's going to have a weird odor, but it shouldn't smell bad. Like it shouldn't be like a foul odor. For an episiotomy and got a quiz. When does the fundus and lochia need to be checked? Every 15 for the first 4 hours, every 15 for the first hour, every 15 for the first 2 hours, or every 15 for the first 3 hours. Good job. Every 15 for the first 2 hours. Okay. And then Q30 times 2, and then every 4 hours. Okay. For our book. Valerie. Why is my lochia pad slide right there? That's the one I was looking for earlier. I must have accidentally dragged and dropped. Okay, we're gonna move on. So episiotomy or laceration. So sometimes you may want to have them lie on their side rather than sit right on that part of the body. Does that hurt? Okay. It may be edematous. We need to check for bruising and pain. So with any kind of laceration or even just trauma to the peri area, if they start to complain of increased pain and pressure in the area, you need to assess it. Okay. Because they possibly can have a blood clot forming in the tissue. Okay. If they do, then we need to let the doctor know because it can continue to grow. Because if they're bleeding within that tissue, it's going to get bigger and bigger and bigger, and then it can possibly rupture. Okay. Sometimes they can even start to lose blood between that perineum and the rectal area. So if they start complaining of rectal pressure, and you're not going to see it because it's not coming out, and you may not even see a bulge or anything. Okay. So if they complain of extra pressure and pain, you need to assess it and let the physician know, okay? Because there could be bleeding within those tissues. Ice packs for the first 24 hours or sitz bath. Make sure that incision or episiotomy is well approximated and together. Use the spray if needed. Use mild pain relievers, and we want to check for hemorrhoids. Omen signs, you're going to put that knee flat. You're going to push on that foot. Okay, do you see any warm areas, redness? Is that calf muscle tender? We're going to check for edema in the ankles, see if it's pitting or non-pitting. And if they do have a blood clot, they're going to have to go on bed rest, okay, because we can't have it moving. So that's when we're going to encourage more on the non-affected side, ankle pumps, rowing, knee exercises, things like that. But on the affected side, you're just going to keep it elevated and not move because you don't want to dislodge that DVT. Emotions. So are the parents bonding? Mom just exhausted, or is there really a disconnect? Okay. How are the family emotions going? I mean, I've had situations where I hear yelling. I run into the room. Grandma's yelling and cussing at dad. Because dad has this girl that he dated before this girl, and she says that he's not the father, and mom's crying over here holding the baby. So sometimes you get in the middle of all that, okay? And so what are family dynamics? What situations do we have going on that we need to be kind of concerned about, okay? What help does she have at home? Does she have any help? Tired moms with no or little support are the greatest risk for postpartum depression. And we want to make sure that she's aware of what to look for with postpartum depression, postpartum psychosis, especially if she has any risk factors. So biggest risk factor, she's alone, she has no support. There's a history of some mental health issues, okay? Has a history of clinical depression, okay? Those increase that risk.
Oh, they do. Oh.
Yeah, if there's already a history, that can increase the risk of developing postpartum depression. And then sometimes it just comes out of the blue, okay? You don't
I
have,
remember when I used it, as soon as the sun went down, I would just start crying
yeah,
for no reason.
yeah.
And then during the day, I was fine.
You're fine, yeah, and it affects everyone a little bit different, you know, and so that's why it's always important to just do a little bit of education. And what I always tell my patients is if you get to that 2-week mark and it doesn't seem like your emotions and mood are doing any better, just call your doctor. In fact, ACOG actually changed their standards about 2 years ago that recommended that every woman have a 2-week postpartum visit. Now, have every doctor change to that? No, okay. And the reason they did that is to follow up and assess for those issues with possible postpartum depression. Okay, last question. When assessing 1 hour post-delivery bleeding, which finding would be normal? Okay, we're 1 hour post-delivery, we're within that 2-hour window, right after delivery. A large amount of blood on the peri pad, small clots, a quarter-sized spot of blood on the pad, no blood. The patient has soaked through the pad onto the blue check pad with a large clot. What do you think is normal? The first one's normal. So remember that first 2 hours, it's going to be like a heavy period, okay? We're going to expect it to be like a heavy period. We're going to expect some nickel, quarter, $half size clots, possibly, maybe even a little bit bigger. And you can have it to like a fist size, but if you continuously have those clots, then you need to be concerned. So they're going to bleed pretty heavy the first 2 hours, and then it's going to get better as that uterus contracts down and causes that area to stop bleeding. Okay. Okay. Let's open up. I'm going to open up that electronic fetal monitoring game real quick. We'll do a quick review of it, and then I'll let you go at 11:30. Y'all can do lunch from 11:30 to 12:30, and then come back at 12:30. And we've got a couple things we're going to go through with postpartum in the skills lab. Okay, so I'll have to get those set up over lunch, and then you have your postpartum case study to do. Okay, for this afternoon.
That one's locked. You're gonna open it though, right?
Yes, I'll open it up. Yeah. So let me open up the electronic fetal monitor game real quick.
Class, right?
Maybe.
So hard.
And they are hard.
I started guessing and I was getting them right, but I know.
But I don't know what I'm doing.
When I was trying hard, I was getting And then that ATI, it kept freezing on me. Did it keep freezing on anybody else?
It took me 30 minutes just to finish it.
First,
I thought it was my Wi-Fi.
Yeah, I just.
Oh, we've been API active.
Brother?
You got this.
I don't know.
let's see.
Like you won?
That's what happens after you cut it. Yeah. That doesn't matter, I always go brown.
No, for the.
PG? No, but it doesn't matter. They always go back to it.
Okay. So here's our strip. I know it's kind of harder to see because it's farther away, but you can see we've got heart rate 150 here. So that box below is 140. So what do you think our baseline heart rate is? I mean, normal, but what's the number?
45.
Okay, 155. So that's normal, right? I mean, 145 it should be. 145 to 150.
But then there comes that line.
Okay, what's that? What kind of variable is that?
D-cell. That's,
Or it's a decel, but I just told you what it was. Variable. And so we're gonna go over here. So deceleration, she has a variable. Okay. So, when it goes down like that in a V or U shape, that's a variable. It is a decel, but it's a variable when it's a V or U shape.
You write notes?
I didn't see the whole thing, I guess.
Oh, you paused it.
When it goes down, it's a variable.
If it goes down like that, it's a variable. A decel is when it goes down, but if it's a V shape or a U shape like that, that's in the varying of the strip, it can go anywhere in the strip. That's a variable. Okay.
Which ones are marked?
So marked is when you're looking at the variability, not just a variable is a decel. The variability is the actual movement within that line that you see. Okay. So at the variability, what do we think our variability is? Because remember, minimal is less than 6 beats. Change. Absent is none at all. It's kind of like a flat line. Moderate is where it has a 6 to 25 beat change. Marked is when it's like really like a sawtooth look.
So it's moderate.
Minimal.
Minimum.
I wouldn't say absent.
Minimal.
It's probably because we're looking across a whole 10 minutes. Okay, so even though here, like right there in that spot, we have a little bit of moderate variability after that decel, but the majority of it's minimal. Okay. Do you see any accelerations?
No.
Okay, because an acceleration on a term baby has to be 15 beats by 15 seconds, right? Okay.
Acceleration is up.
Where it goes up, acceleration, it accelerates. Kind of think about a car when you push on the gas and you accelerate, your speed goes higher. Yep. So do you see any accelerations?
No. So
Okay, absent. So with the categories, you know, this is something that I don't expect you to understand, okay? But the category on this one is going to be intermediate because she is having a variable. She's having a decel, okay? So it's not normal. That's not normal. So now contractions, okay? Okay, let me pause it right here when our strip starts over. Okay. So we've got 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes, 6 minutes, 7, 8, 9, 10. Okay. We have 1, 2, 3, 4, 5, 6, 7. Because this is coupling. Okay. 7 contractions. Do you think that's too many or not enough? Or just right? Too many. Okay. We should have 5 or less. If you have more than 5, it's called tachysystole. If you have more than 5 contractions in a 10-minute period, it's tachysystole. Okay, or hyperstimulation, either word. Now, remember how we talked about our resting tone? Are we going down to resting every time?
No.
No, so that's a little abnormal, right? Okay. So would you say this is a normal frequency, tachysystole, or do we need more data?
Tacky.
Tachysystole, okay? There you go. Let's look at one more. Okay. So immediately, what do you think our variability is? Okay, remember variability is a change in the heart rate.
Moderate.
It's smart.
That's more than 20.
It's marked, because you've got more than 25 beat changes. Okay, so that's marked. Remember how I talked about it's kind of a sawtooth look? Okay, so we've marked. So our baseline, so now we're gonna pause it because we gotta, this is when you have to look, okay? So I've got to be able to draw a straight line through. Now I've got marked variability, so this is gonna be a little bit harder to figure out what our fetal heart rate is, okay? But if I look here, kind of between my marks, where I'm at center in a way, and if I were to draw a straight line across where those level parts are, what would you say my fetal heart rate is? It's normal. So I'm at 120. So I'm about 120, 115 to 120. Okay, so is that within range? Okay, so that's a normal. So, okay. So this one is a little tricky, okay? So they're saying intermediate because it is at 110 sometimes. Okay. But if you're looking at it, we know anything above 110 is normal, but we're also looking at our variability. Okay, so that's why they're saying intermediate, because it's marked and then it's kind of really hard to tell where that baseline is.
So usually if it's marked, it's not gonna be.
Right, it's not, no, there's something going on. So can we tell if there's any accelerations?
Yes. Well, kind of. Let's let our baseline.
Okay, but is that a true acceleration?
No.
Or is that just our variability?
It's just variability.
It's just our variability. Because remember, with your accelerations, you're going to kind of see that, yeah, kind of like that rise and fall.
Oh.
None. Ha.
Okay, this one's tricky because right. The reason they're saying not any is, or NA not applicable, is because you really can't tell, right? Right.
So we couldn't really tell because we couldn't see the.
Right, because you have marked variability, so it's really hard to assess if there really is an acceleration. So decelerations, do we have any decels?
Yes, but no, because we can't really.
So are we gonna be able to see them? So it'd be an NA.
Oh, is a decel like the same exact as the acceleration?
Yeah, it goes down.
It's peak, bottom peak.
But there's
Yes,
one
a nadir, that's the nadir, yep.
No, we don't.
No.
So
I
absent.
say NA.
Absent.
NA or variable? NA.
Absent. I'm with Luce, NA.
NA.
So let's see.
Oh.
Whoa.
Good, because again, we have sun drops. Remember, yeah, we have sun drops, so we really can't tell because our variability is so marked. It's really hard to see if there even is a possible decel there, okay? So do we think this, just a little bit of knowledge we have, do we think it's normal, intermediate, or abnormal?
Abnormal.
Right, because even though it's marked variability, this is still not severe enough to where something's really bad wrong with baby,
It's
okay?
not really low and it's not really high.
Right.
We have some movement.
We have some movement, we have some variability, it's kind of marked, it's higher than we want it to be, okay? So now let's look at our contraction pattern. Let me start it again and get it to the beginning. Okay. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. How many contractions? Well, can't really count that as a full one. Okay. 1, 2, 3, 4, 5, 6, 7, 8.
So tacky.
Let's see more.
5 or less.
5 or less in a 10-minute period.
So it's tacky.
Tacky. Okay. And do you think we need more data? Because we can see the defined contractions. Okay. So that one was a harder one, right?
Yeah, that was so hard.
It's tricky.
But it, like you telling us really helps now.
Yeah, to see it.
Yeah.
And so, like I said, you're not going to be a pro at reading strips. The main thing is when you do the NCLEX, you've got to be able to at least see baseline. if there is decels, and they're not gonna give you a strip like you just had.
Okay.
That's not gonna be a strip they have, okay? This,
Well, not those.
okay,
The normal one. I don't know.
okay, so first let's look at our baseline,
I say normal.
Normal.
okay? 135, 140, okay? So that's normal, we're within range, okay? What about a variability?
It's minimal.
Is it minimal?
Yeah, I would say moderate actually.
If you look across, you really have more than a 60 change, because look, your whole box is 10 seconds. You know, and a lot of that's within that. It is still within the 10-second block, but it's outside the 60 range. Okay. What about A cells? Let's watch the rest of the strip here.
Well, not really, because, yeah, I know.
Okay. Look at this.
Or would it be NA?
So remember, what is it considered an A cell?
You would be.
Mountain.
Kind of looks like a little mountain, but what's the definition? 15 by 15. Okay. 15 beats by 15 seconds. Okay. So what's our baseline we said? 135. So what does this go up to? 150. How many beats long is it? 25. So does that meet the guidelines for an ASAP? Okay, let's see what they say.
Not fair, you're an OB nurse.
So yes, we kind of expect to see that big A cell, but remember, 15 by 15. That's all it has to be considered an A cell. So that's a pretty minimal change, right? So you look at this and like, oh, I don't think I see one. And you only have to have one in a 10-minute period to be considered reactive or a good strip. Okay. So there's your one. Okay. So do we see any D cells? Okay, let's keep going a little bit and make sure. So not really, right? Because remember on D cells, late can be any amount of time, but it's going to be after the contraction starts. Earlies have to at least be 15 beats below. Variables are going to be the V or the U shape. And I don't see anything on there that looks like any of those. Do you? Okay. So do we think this is probably a normal strip? Okay. Now let's look at our contractions. Okay. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 1, 2, 3, 4 contractions. Okay. So now on this one, because we've got normal contractions, let's look at the frequency. Okay. So what's frequency?
How long do they are?
From the start of one to the start of the next. Okay. From start to start, that's your frequency. Okay. So look, our contraction's not being nice to us. It's not starting on our 1 minute. Okay. So this is where you have to kind of eyeball. And I literally use my fingers on the screen when I'm at work doing this. Okay. And I've done this for years and I still have to mirror or look. Okay. So it kind of starts around this point in the contract or in the minute. So at 30 seconds. Okay. So I'm going to carry over to the next 30 seconds in my next minute. Okay, so I've counted 60 seconds. To my next 60-second mark. So how many minutes was that?
2.
2. Okay, so again, I start about the 30 seconds again. So I've got 60 seconds, 60 seconds, and then 60 seconds. 60 seconds, 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 60 secon So it's not a full 3 minutes, but it's not 2 minutes either. Okay. So if I were doing this strip from there to there, I'd say about 2.5. Okay, because you're just kind of averaging. This one was nice. It started on the line. Okay. So 1, 2, 3, and a little bit more.
2.5 to 3.
2 to 3 minutes.
2.5 to 3, 2 to 3. That would be about appropriate. 2 to 3 would be your appropriate frequency. So every 2 to 3 minutes, this woman is contracting. Okay. Now what's duration? How long? So from the beginning to the end, right? So remember, each box is 10 seconds. So we've got to count. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay. So what I usually do when I'm looking at a strip, and I'm having to chart contractions, I try to find the shortest contraction and the longest contraction. Okay. Because then I'm not going to have to go through and count every one of them. So if I count my shortest contraction, 1, 2, 3, 4, 5, 6, and 1 10. So it's 60 seconds to 110 seconds long for my 10-minute range. Okay, so that's how you document it. You're looking at that full 10 minutes. You're looking for that baseline where I can take and draw a straight line through my fetal heart rate and kind of keep my line straight. So on this one would be about 135. Okay. Do I have A cells? I have 1. Do I have D cells? No. Okay. I'm contracting every 2 to 3 minutes, and they're lasting 60 to 110 seconds long. Okay, does that make more sense?
Yeah.
Okay. Y'all want to do one more?
Yeah.
Okay, let's do one more. Oh, wait. So we got normal frequency. That's what I'm wanting. On that worksheet that you're doing, that's what I want you to tell me. What's your baseline heart rate? What's the variability? How often are you contracting? Frequency? How long are those contractions? Duration? Okay. Do you see any D cells? If you do, what are they?
I didn't put the category when I turned it in.
And that's fine. The categories, if you don't do the categories, I'm not worried about categories. I mainly want those things. Now, I want you to tell me what the number is. Tell me what the actual heart rate baseline number is. Okay. Okay, on this one, let's look. Get to the beginning of it, and we're going to pause it. Okay. So first, let's look at our baseline. So yeah, 155 because we're at 150. So if I were to look and see, I'm more closer to 155. Okay, if I were to draw a straight line through there. Okay. So is that normal? Okay, what about variability?
It's absent. What about that one?
Well,
I think it's
minimal.
minimal.
I'd say minimal.
Yeah.
Okay, because you have still a little bit of variation. If you look, there's some variation there. Okay, do we see any acceleration?
Not really.
Not really, but
Well,
no, I would say.
Remember, if our baseline's 155, do you really see anything on there
No,
that goes up to 170?
no, not really.
Okay. So what about these cells?
Yeah, I would say.
I always get mixed up. How do you know between early and late?
So early mirrors, remember the nadir, the bottom of that D cell is going to match the top of your contraction. Okay, late is going to be after.
Okay, so early is when it matches, late is when the contraction and then the.
Yeah, and then variable just happens.
There's a contraction right there, and then there's a D cell right there, so it's late.
Okay.
Variable. Always late.
Now,
Variable has U's and.
right.
There's a.
Okay. Do you see another D cell anywhere?
No. Well, that little one right there. That was the one that's.
But it's too little
It's
to,
just-
that one,
Yeah, that one.
like a little.
Because remember, lakes, do they have how deep do they have to be?
They don't have.
They don't have to be.
Oh.
Okay, it could be subtle. It could be just a small
But
change.
it's after contraction.
And
so
it's after
like-
contraction.
Yeah.
Okay, so is everybody seeing what we're talking about?
Yeah.
Okay, you see this little bit of dip of heart rate? Okay. You see the peak of your contraction. If you go up, that starts after, so it's late. It doesn't have a requirement of how deep it has to go. It can be any depth.
Only if it's early.
Only if it's early. Okay. So late. So do we think this is normal, intermediate, or abnormal? Okay.
Oh, yeah.
Because it's still a D cell, but we still have some variability. Okay, we're not absent. We really don't have any A cells. This is still concerning. Not the best strip I've ever seen, but it's not one that I'm going, oh crap, what's happening? Okay. Now let's look at our contractions. So we have 1, 2, 3, 4, 5, 6, 7. So we're tachycystole, right? Okay, too many because we have more than 5 in that 10-minute period. Okay, so we're tacky. Good job. Look at you guys. Okay. So, like I said, just go in there and play with it. You know, because this is the only way with fetal strips that you get somewhat of what's going on. And the main thing, like I said, I only want you to be able to really recognize, are there A cells? If there's a D cell, what kind is it? And what's your baseline? Contractions, frequency. How do you measure frequency? How do you measure duration? Okay. And how many is too many? Okay. So today, have lunch. Okay, come back at 12:45 since I kept you over a little bit. Come back at 12:45. We'll meet in here and then we'll break up into groups to go into the skills lab to look at the few things we're going to do in there. Okay, and then I will open up the postpartum case study for you guys to do. Okay. And I will email you guys on Zoom. Just do that postpartum case study. And then I probably will have a little short worksheet for you to do for the stuff that's in the skills lab, but we'll go over that stuff too whenever you guys all come in to do your makeup. Okay?
Okay.
Okay, thank you.
You're welcome. See you guys later.
Bye.
Finished it, but I really jacked up the frequency.
You're fine.
Okay.
As long as you practice it and you kind of
And then
understand.
we can still turn in the 60% one, right? Because I want to keep practicing.
Yes.